Good morning, everybody.
Good morning, sir.
Good morning, Manoj. Good morning.
Sir, should we start?
Yeah, please go ahead.
Okay. Good morning, everyone. A very warm welcome to all our participants for this Rapid Revision Course 2026. We are glad to have you here, and we hope this session will bring you to revise the important topics of pediatric dentistry in a very fruitful manner. You will have the clarity, confidence, and the focus after listening to the lectures from our expert speakers. I would also extend my gratitude to ISPPD head office who have trusted us and allow us to host this rapid revision program for the year 2026. Because of this support and the collaboration, we are able to bring this learning platform to everyone. So let's make most of it in next 2 days. Hope you have engaging and fruitful session. With this, I would like to invite our President, Dr. Surendra Baliga, sir, to address this meeting on behalf of ISPPD. Sir, over to you.
Thank you so much, Dr. Manoj. It's my privilege to invite all of you, all my esteemed faculty members, all the speakers, and the exam-going postgraduate students of the year 2026-27. At this outset, I think I would like to congratulate PGI Chandigarh, who had been the responsibility of hosting this rapid revision for postgraduate students. They have done a wonderful job in selecting the best of the best in this entire 3-day rapid revision program. The postgraduate students are the main backbone of pediatric dentistry at this point of time. If you look at the way things are progressing, they are the flag bearers of this specialty once they complete and they come out. And at this 3 years, which we studied for 2 years, these postgraduate students from the last 20 years have been given an opportunity to study the same syllabus and curriculum in 3 years to master their skills in the best possible way. The society has made it an effort to make sure to have this rapid revision for both first year exam going students and the final year exam students. This is an effort from the society to make sure that the students are well prepared to appear for exam, both from the theoretical and the clinical perspective. But all of you know that exams are just an ongoing process. It's my request to all the students who are appearing to make sure that they utilize this opportunity to be the best clinicians. They should know that what is learned in theory has to be applied from the clinical perspective. I've always believed in one simple statement that education is important. Qualification, education, there should be a difference. All are qualified, but everybody has to be educated. So if you look at the current perspective pertaining to the National Dental Commission, the National Dental Commission also is working towards making sure that the undergraduate and postgraduate curriculum gets uplifted, and they are making an effort that after 20 years that the curriculum revision workshop are conducted, and might be in the due course of time the postgraduate curriculum also will be upgraded to the current decade. We have the best of the speakers in our entire 3-day workshop. Some have sent, I think, video lectures are on live. I request all the speakers to be there on that particular hour to address the students' questions. And we expect that the students also to have asked the simplest of the questions, because there might be so many doubts in the mind. This is a good platform because you can ask online questions, and if you required, you can take the numbers and or mail addresses of the speakers and to address your all questions which might be of the simplest of form. So at the end, I would like to wish all these students all the best for the exams, and I congratulate the entire team and our society on whose behalf I'm talking. And we are definitely going ahead with student-centric methods. Thank you so much. Jai Hind.
Thank you, sir. So with your permission, can we start the program now?
Please go ahead. No formalities. Let's start with the program. It's crossed 10 o'clock.
Okay.
Yeah. Thank you.
So I would like to introduce our first speaker, Dr. Sharad Ashokan sir, the principal at KSR Dental Institute and Research, Tamil Nadu, serve as the editor-in-chief of JISPPD along with the executive committee member of SAPAD and the education committee member of IAPD. Sir has recognized as the youngest and the third pediatric dentist in India to complete the doctorate in oil pulling therapy. Recipient of several prestigious honors including Young Pediatrics Research Award, Health Excellence Award, and Young Dentist Award. Honored with Star Pediatrician Award, Fellow ISPPD, and Sam Harris Travel Bursary Award at 29th IAPD Congress, Netherlands. Received the Best Research Award at 30th IAPD Congress at Cape Town, South Africa. Sir has delivered more than 160 lectures, plus having 120 publications in peer-reviewed Indic journal. Sir, over to you, sir. Welcome to the Rapid Revision course.
Thank you, Manoj. Thank you.
Can we play the recording of?
Hello, everyone. This is Dr. Sharad Ashokan. Firstly, I would like to thank the President, the Secretary, the General of ISPPD, and Dr. Manoj for giving me this opportunity to be a part of this rapid revision program organized by ISPPD. I'm happy to be here. I've been a part of this program since its installation 7 years ago, and I'm happy to share some of my experience in child psychology. The topic given to me today is clinical implications of the theories of child psychology. So where do we start? So any question which is asked in child psychology in your exam, I think you have to go with the definition of psychology. Psychology is a scientific study of behavior and mental process. Behavior is anything which you can observe, record, and measure. And mental process is something which you cannot see. So I think the postgraduates need to understand there's a difference between what you can see and what you cannot see. Behavior is anything which you can observe and record and measure it. And mental process is something which we cannot see. The emotions, the memories, the thoughts, the beliefs, the perceptions, anything which we cannot see in what a child would probably think is the mental process. So as a pediatric dentist, we have to study both the behavior and the mental process for children. And child psychology is a part of developmental psychology. And developmental psychology is the study of how individuals grow and change throughout life. Right? Child psychology is how children grow and change from birth till about adolescence. So this should be the introduction to any essay question asked. And then what do we do? So be it a theory question or a practical experience which you should have as a postgraduate student, or after you finish and you start your practice, I think the first thing you need to do is, as soon as a child walks into your dental practice, I think the first thing is like the Harry Potter's movie. You place the sawdust hat on the child's head and divide the child based on his age. And the standard classification which we have is the Stone and Church classification. So you need to know in which age category the child falls into. So if the essay question is asked, a 2-year-old child throwing temper tantrums, 4-year-old throwing temper tantrums, a 6-year-old cooperative child. So you can divide or classify the child based on Stone and Church classification. Because I want you to understand, every child psychology theory is interlinked in between. So a child in the oral stage in Freud will be in oral sensory state in Erikson, and will be in sensory motor pre-verbal stage according to Jean Piaget. So that means we take a little bit from the emotional development, a little bit from the learning and behavior, a little bit from cognitive theory, and apply this the principles of psychology in behavior management. When I was a postgraduate student, behavior management was entirely different chapter and nobody taught us child psychology. Now we understand that child psychology and behavior management is closely interlinked, and this is totally connected, and we have to understand the principles of psychology and apply that in behavior management. So the first thing you will do is place a sorter's hat and identify the age category in which the child belongs, because there is a particular characteristic feature which is there for every age group. Let us say less than 2 years, everybody knows the child has a fear of strangers, separation from the parents. So if you come to oral stage, oral sensory stage, I think it will be trust versus mistrust. Trust versus mistrust, a child less than 2 to 3 years of age will have fear of strangers. A dentist acts like a stranger, and you cannot separate the child during the dental procedure, even during examination or during the dental treatment. The mother has to be there in the dental office. The parent has to be inside the dental office. The child has to be placed in the mother's lap, and we do the treatment. So that is the application. So I think we go back and try to say, what is the age group? In each age group, a 4-year-old child is scared of bodily injury. That means injections could be dangerous. So 4-year-old child, injection, white coat. Injection, white coat, this is classical fiduciary. So I want you to understand each age group is going to be related to some theory. Each age group has some specific factor or characteristic feature which is present in a child, right? A 5 to 6-year-old likes to talk about its possessions, right? Its favorite cartoons. It likes to talk about imaginary play, right? So you can talk about his school, right? And 7-year-olds, they are actually trying to be both brave. Sometimes they are very coward. So they alternatively are brave and coward. So sometimes you have to talk, and establishing communication with these children becomes extremely easy. I keep telling my postgraduate students that above 7 years of age, it's not like we are able to treat children. Children allow us to do the dental treatment. That's how it goes, because they understand their cognitive development has increased in such a way that we are able to explain something and they have a logical reasoning and they understand what we are trying to do for them. 8 to 14-year-old, they learn to tolerate. So obviously, it's going to be very easy for us to treat these children. So the next thing I want you to do is, first is age of the child. The second one is, according to Frankel, how does the child behave on the first dental visit? Is he definitely negative? Is he negative? Positive? Definitely positive. If the questioners are telling you the child is throwing temper tantrums, that means it is in this stage, right? It isn't definitely negative. If the child is saying it's shy, but apprehensive, but accepts, it is type 3 in Frankel. So the question in your essay will tell you an age group and then some characteristic feature of the child, which will either fall into Frankel or it will fall into rights. They might use a word uncontrolled behavior, defiant behavior, timid or shy behavior, or a tense behavior, or a whining child which allows the dental treatment. So based on age and based on Frankel and Wright, you categorize the child first. That's what we need to do. And we need to understand here, Wright's classification was given in 1975, and in almost 25 plus 14, 39 years later, Wright has added something called passive resistance, commonly seen in adolescents. They passively resist you from doing the treatment. That means they don't establish eye contact. It's difficult to establish communication with them, and that's going to be important. Apart from age and Frankel's behavior rating scale and Wright's cooperative behavior, I think I want the postgraduate students and any clinician here to understand the difference between behavior management problems and dental fear and anxiety. Most of the time, we ought to think that these two things are intermingled. It's the same. We can interchange these words, but they are not. All children who exhibit behavior management problems, who are lashing out their extremities, squirming on the dental chair, shying and running around and hiding behind the mother, are exhibiting behavior management problems. Doesn't necessarily mean that all children who have behavior management problems actually have dental fear and anxiety. A lot of children who exhibit behavior management problems might be actually not scared. And most of the children who who have dental fear and anxiety, or all the children who have dental fear and anxiety, need not necessarily exhibit behavior management problems. They might be really, really scared inside, but they might just allow you to do the treatment. So it will take you some time to understand that whether the child is showing just behavior management problems. The child is just showing behavior management problems. Sometimes it's important that you throw the mother outside. Time out, omission for the mother, right? So we will see that in the later slides, but I want you to understand 3 basic things before you jump into child psychology. Any question or in practice, 3 things. Categorize the child based on Stone and Church classification. Categorize the child based on Wright's classification and Frankel behavior rating scale. Check whether the child has behavior management problems or dental fear and anxiety. So unless we have these things answered, we might not be able to comment on the right answer. So the theories of child psychology, we have different perspectives of psychology. There are 5 different perspectives in psychology. But for convenience, we divide them in developments, means emotional development, cognitive development, learning and development of behavior. And these are the theories which we generally see in our book and what we read. We also divide them into grand theories, major theories, and minor theories, but I think this is the best way to go about it. So if there is a question on personality development, or if there is a question on psychodynamic theories, then you write psychosexual theory and psychosocial theory. The usual question is, what is the common things between these two theories and what is the difference between these two theories. I think we'll do this in the next few slides. Psychosexual theory was put forward by Sigmund Freud, and I think you really need to understand that Sigmund Freud was not a child psychologist. Just a second. He was not a child psychologist. He was a hypnotist. He treated adults who were very successful lawyers, but they had depression. And then he found that basically these people had some conflicts which were predominantly either aggressive or sexual conflicts the first 5 years of their life or the early stages of their life. So then he decided that the personality of a person is basically based out of three hypothetical structures, and he called it id, ego, and superego. And everybody knows that id works on a pleasure pain principle, the ego works on a reality principle. But what I want you to understand is this id works or causes some tension, and the tension is called libido. This libido or the tension created by the id acts on one part of the body at different ages of life, and the part of the body in which the id creates a tension is called an erogenous zone. So we'll look at the different stages because we're calling it oral stage, anal stage. So oral cavity becomes the erogenous zone. The id creates a tension in the oral cavity. The id creates a tension in the anal region. Sigmund Freud called it psychosexual theory because he strongly believed that the conflicts were the reasons of the personality development. Erikson was a friend, was a student of Freud, then worked with Sigmund Freud, became a good friend of Sigmund Freud. He considered that yes, there was conflict, and this conflict was resulting in the personality development, the emotional development for a person. But then he had a subtle difference here. He wanted to say that the child was not alone when the child was going through the conflicts. The child always had a social environment on which the child was working. The social environment could be the mother, the parents, the family, the school, the peer group, the friends. And these people could help the child go through the conflict. So the conflict, as we know, trust versus mistrust, autonomy versus shame or doubt, initiative versus guilt, industry versus inferiority, identity versus identity fusion or role confusion. So you know that these are the conflicts. I want you to understand Freud and Erikson believed that these conflicts existed. So Erikson also believed that these conflicts existed. But Erikson felt that these conflicts were not handled by the child alone. The child has help from the social environment. The social relationship plays a major role in the personality development or the emotional development of the child. So what is the clinical implication we have here? Trust versus mistrust. The child is born into this world. The child is only able to communicate through crying, oral cavity, whether the food is coming inside his mouth, does he get the food or does he get the food? That's what Sigmund Freud said. Erikson said it's not just about the food, it's also about the love, the warmth and care, and whether the child develops a sense of hope in this world. You will also see that, try this, yes, that's the mode, the most characteristic features, the most characteristic emotions which develop in that particular stage is called the mode. A child is born into the world with a sense of hope. Then he has a will to do it. Then there is a purpose to do something. Then he competes, and then he develops a sense of fidelity. These are the emotions and the personalities which he develops in different stages. But what happens in the first stage? The child is born, trust versus mistrust. Do I trust anybody or not? So the child is not going to trust any stranger. As I told you in the couple of slides previously, that the child has a fear of strangers. 0 to 2 years of age, fear of strangers, separation anxiety. So I think I should probably add, or you can probably add another a column next to social relationship, and you should add one thing right there, and probably you will write it as the fear of strangers or the separation anxiety, which we cannot do in the dental office. That's the application of Sigmund Freud in the first stage. Autonomy versus shame or doubt. The child is toilet trained at this phase. So I think I should move to the next slide also. So you can see here, there is an important event which is happening in each stage. One is feeding. So when the child gets food, right, and has developed a sense of trust in this world, right, there's no separation anxiety. It doesn't mean that you can send the mother outside, but that's how the development of personality develops in a child. So it's related to a most important feature, but then you write in the second stage, toilet training. When toilet training is done, if the child is toilet trained, he develops a sense of self-governing capacity, which is called autonomy. If somebody ridicules the child that he's not toilet trained properly, he feels guilty or he feels shameful of his act, and then he has a doubt over his capacity, right? So he has a doubt over the capacity and is shameful, he feels shameful for his act. That is what is called autonomy versus shame or doubt. So this is what happens. The desire to be self-directed is autonomy. The child develops a sense of autonomy in second stage. The third stage is basically called phallic stage. Phallic means penis. Sigmund Freud would have probably just called it as, I'm going back to the previous slide. Yes. Third stage is called the phallic stage, but then Erikson calls it locomotor genital. That means the child is moving around, the child explores. Exploration is the key term there. When the child explores his external world, he starts to explore his body also, and then he finds that one part of the body is different for the boy and the girl. Right? When boys and girls play together, they find that you have two noses, you have two eyes, you have one nose, you have 2 ears, but there's one part of the body which is different, and that's what is causing the castration anxiety and penis envy. We always talk about Oedipus complex, Electra complex, castration anxiety and penis envy, but the problem is we have to talk about exploration. The child likes to explore. So what would be the clinical implication when a 3-year-old child walks into a dental office? The most important thing is you have to allow the child to explore the dental environment, right? You allow the child to see what is happening around, other children getting treated. Probably you can show them a 3-way syringe, make them move the chair up and down. So he can try and explore, he can touch a mouth mirror, right? So he can touch a probe and he can probably explore and he can feel more comfortable. This is also a kind of systematic desensitization. When you allow the child to gradually, successive approximations, right, that you keep increasing what is probably scary for the child, and then you make the child understand that there is nothing to be scared of. Exploration is a kind of systematic desensitization. It's not just tell, show, do. You can also mention exploration as systematic desensitization. The fourth stage is industry versus inferiority, is the conflict which is happening in the fourth stage, which is called the latency stage. This stage is called latency by both Erikson and Sigmund Freud. Competence, children ready to compete. Children go to school, pin drop silence, and they will stand in a line. Rule book, they go by what the teacher says. So if you compete with the child saying that probably you have to hold the suction, the child will say, hey, I can do it. The child will want to compete with you to show that he can better do it. So the child wants to compete, and you have to allow the child to participate in the treatment planning and in the procedures. Right? The last stage is the adolescent stage. Erikson would call it adolescent stage, and Freud would call it as genital stage. The conflict is identity versus identity diffusion. Fidelity, being loyal, is very important for these children. It's very difficult in adolescent stage, as I told you, passive resistance. It's very difficult for you to establish eye contact, talk to them, right? A 5-year-old, 6-year-old, you can probably say, oh, I also studied in the same school like you. I have my favorite cartoon like yours, and then they would be impressed, or they might be even wondering how the dentist also likes the same thing. But an adolescent person would just not really care about what your likes and dislikes are. So it is not easy to establish communication with them because peer group influence becomes extremely important. They're not bothered about authoritative figures like parents and those things. So it is difficult in establishing communication. That's something which we have to understand when we are talking about adolescent stage. I also want to tell you about concept of fixation. The child is supposed to move from one stage to another. And if he's staying in that previous stage itself, it's called concept of fixation. In your thumb sucking essay or short notes asked to you in oral habits, I think it's mentioned as classical Freudian theory as one of the theories for thumb sucking. And I think you should mention it as concept of fixation and not classical Freudian theory. It's the fixation concept which is making the child do the thumb suck. So let us quickly see the difference between psychosexual theory, psychosocial theory. The stress is on the sexual urges, as I mentioned to you. Here it's more about the social influence. Ego, the reality works here. Here the behavior is stemmed based on the conflicts, as I mentioned earlier. The second theory is, I have to really go quick. I don't know whether I'll be able to even finish all the 6 theories, but then I'll try my best to do this. If I have any questions, and then I'll be more than happy to take the questions. So learning is a relative permanent change in the immediate or potential behavior that results from experience. One time you learn something, you've not learned it for lifetime. So trust me, whenever you make a mistake, then immediately you will probably do something right. When a seminar goes wrong, then you do a seminar very good the next time. But it doesn't happen for a lifetime change. It's only a relative permanent change in the immediate behavior, and that is out of the experience you received from the department, right? So learning theories are generally classified as associative learning and non-associative learning. As non-associative learning, when there is one stimuli and one response, it is called as non-associative learning, right? Associative learning, classical conditioning, operant conditioning, and social learning theories will come under associative learning. And I would want you to understand that all these theories are part of associative learning. Okay, so what happens in classical conditioning? Okay, so a bell is a neutral stimulus that does not evoke any response. The bell is not going to cause salivation. The bell is given and then the food is bell and the food, and the bell and the food, and automatically the neutral stimulus bell becomes a conditioned stimulus. After some times, after some days, after continuous experimentation, the dog is trained, the dog is conditioned. On ringing the bell, it starts salivating. Likewise, a white coat does not cause a child to cry. A white coat injection can make the child cry because the child is associating all white coat people will cause some harm, or they might cause some injection or a drill or cause some pain to them. That is what is called classical conditioning. So classical conditioning, the child acquires some information, which is acquisition. He goes from one dental office to another dental office to another dental office and says, hey, all these guys are the same. It is generalization. Then he walks into a pediatric dental office and the pediatric dentist tries to show that he's different from the rest of the crowd, discrimination, and he makes sure that the pediatric dentist makes sure that the child forgets or loses what he acquired, that is extinction. Always remember, in pediatric dentistry, discrimination and extinction would be fantastic. But if you don't treat the child in a proper way, thinking that 4 times the child has walked into the dental office and it will be easy that this time he'll be okay, the child might suddenly remember what he remembered about, what he acquired about the dentist and say, okay, these are all the same guys, right? And he has something called spontaneous recovery. So in pediatric dentistry, do not allow spontaneous recovery to happen. When it's a bad acquisition, discriminate and cause extinction of the acquired behavior, and do not allow spontaneous recovery to happen. That is what I think you should write it in your clinical application. Operant conditioning, there was a rat which would press a lever and take a cheese pellet. If the rat did not behave properly, the floor was electrified. The rat was allowed to escape this place and run into another extension of this chamber. This is called the Skinner's chamber, right? Skinner left a rat inside and he allowed the rat to escape this electric shock by extending this box, right? So he came up with 3 different aspects, which is called reward, escape, and punishment. These were the 3 things which he initially gave. The reward, the rat could go and press the lever and take the food. Whatever the rat did not like, the rat could escape that situation. And whenever the rat did not behave properly, he gave an electric shock and gave punishment. This theory, operant conditioning, is also called as stimulus response consequence theory because everybody learns out of their consequence. It is also called instrumental conditioning, right? And the basic behavior management technique, which we have the same positive reinforcement, negative reinforcement, timeout and omission, or punishment, is called contingency management. So contingency management works on the principle of operant conditioning or instrumental conditioning. I'll summarize all this at the end, but then I'm trying to give you an example. All positive reinforcements, positive reinforcers, that will come under rewards. Any negative reinforcement is something phenomenally which will work in pediatric dentistry. I think PGs have to learn and master negative reinforcement. Whatever the child does not like, do not make a mistake. An unpleasant stimulus which the child does not like is withdrawn, removing the unpleasant stimulus. If a mother is a pleasant stimulus and the mother is removed, it is omission or timeout. It is a pleasant stimulus, right? So negative reinforcement, child does not like a high-speed handpiece, shift to a slow-speed handpiece. From a slow-speed handpiece to a spoon excavator. If you have to do extraction on the upper arch and lower arch, ask the child which one does he want. The child is allowed to think. The child is made to understand as if he has control over the situation, right? So I want you to understand the difference between these 3 theories when I finish this. So I go to the observational learning theory, also called as social learning theory, vicarious learning theory, right? We have two types of models here, the coping models and mastery models. Vicarious means learning from other person's experience, right? If you're standing outside your principal's office or HOD's room to get a leave letter signed, and you see a postgraduate student standing inside being fired by a HOD, you wouldn't go inside. That means you learned that you don't have to go inside because you're not going to get your leave sanctioned. It is learning from other person's experience. Vicarious means learning from other person's experience. You learned it by just observing something happen. You did not actually experience it. So the basic difference between operant conditioning and observation learning is, one is your direct experience in stimulus response consequence, which is operant conditioning. In observation learning, it's learning from another person's experience. What are the four processes? Attention, retention, reproduction, and motivation. The child has to attentively see, retain what he has seen, reproduce it. Nobody reproduces without motivation. So modeling is the behavior management technique which is based out of this. So one of my favorite slides in child psychology will always be these three things, right? If you ring the Pavlov's dog door, then he will start salivating because he has no control over the situation. The basic difference between first two theories, stimulus response consequence, and as I told you, Bandura's is stimulus response consequence observed in other people. But then these two have a basic difference. Pavlov's dog cannot take the food if he wants to. But Skinner's rat can press the lever and take the food. So likewise, a child who wants to take a reward can behave properly and take the reward. You tell the child that I'm going to throw your mother outside if you're not going to behave properly. Who decides whether the mother has to go outside? It is the child's behavior which decides. The consequence decides whether the mother goes outside, right? You tell the child tells you that I want to take a break. He's raising the hand, right? Enhancing control, contingent escape. These are words which you see in your AAPD reference manual in behavior guidance. Contingent escape or enhancing control. The child is allowed to raise the hand after 10 seconds or when he wants to take a break. The child has gone through the dental treatment and then he is allowed to escape the dental treatment. This is negative reinforcement, removing the unpleasant stimulus. The child is earning that. The child is made to earn rest. We call it as earned rest. So that is based out of the child's experience. The child is allowing the decision to be made. That means the child is making the decision that I need a break. So that's the basic difference between stimulus response and stimulus consequence. So I've just summarized all these behavior management techniques, and you have to understand operant conditioning, instrumental conditioning takes care of most of the behavior management guidance techniques which we see in our AAPD reference manual. Modeling or imitation, as I told you, is based out of social learning theory. Anything which is not in control of that person, whenever you tell, show, do, those kinds of things, showing around the clinic, desensitization protocols, reframing, all that is based on stimulus response theory by Pavlov. The last theory is cognitive theory. I do not know how much time I've got. I think maybe 5-10 minutes. I'll quickly rush through this. Cognitive theory, I think you need to understand the child acquires something. Cognition means knowing and understanding. I think I want you to understand this word. The first line in cognitive theory is knowing and understanding. The child gets to know and understand certain things, right? The child learns something by acquiring some new information, which is called as schema. He has a schema. For a particular stimulus, how does this world react? How does the response have as a schema? These schemas become structures, and these simple structures becomes complex structures, right? So this I can explain by a simple thing, right? A child seeing a bird fly, the next day he sees an aeroplane and he'll say it's a bird. So anything that is white and flies will become a bird, and next day when he sees an aeroplane, the mother will say it is not a bird. The child has to disequilibrate and say what's happening, that's not a bird, okay? The next day he will show a black thing, and now he doesn't understand it's a bird. First day he saw something white and it was flying. The next day he sees a crow, which is a black bird, and it's flying, and he doesn't understand it's a bird. So the child is made to assimilate new information and accommodate this information, and he has to have a balance. Incorporating information into existing schema is assimilation, accommodating it is accommodation, then it equilibrates. A new thing happens, right? And you show a peacock and it says it's a bird. The peacock is a bird which cannot probably fly. then he thinks he disequilibrates, then he understands, okay, all birds do not fly. So the child learns by assimilation, accommodation, equilibration, disequilibration, assimilation, accommodation, equilibration, disequilibration. And Jean Piaget strongly believed that children 0 years of age are completely egocentric at birth, and they go through a stepwise, consistent expansion of knowledge. He believes that children born are little Einsteins, right? That means when they are born, they start to explore. Unlike in phallic stage, when exploration happens in Sigmund Freud and Erikson, cognitive theory strongly believes children start to explore right from birth, right? And you see in sensory motor stage, object permanence, again stranger anxiety, learning via senses, touch, taste, sight. Preoperative stage, pretend play, symbols, egocentrism, right? Concrete operations, they have maths in school, so now they have conservation, reversibility, understanding, logical thinking, right? The last stage, formal operation, abstract thinking, hypothetical thinking, all this happens. And this is called as invariant developmental sequence. I want you to strongly understand that cognitive theory is extremely important to establish communication with children. You cannot use words like pulpectomy to a 3-year-old, 2-year-old, and you use euphemisms because you think that the child will be able to understand a different alternative word which is easy for them to understand. A rubber dam becomes a white coat, right? So does it become a white coat? It becomes a raincoat, sorry. A rubber dam becomes a raincoat, right? An LA, a 3-way syringe, everything. We have a different name to it, and that happens based on the cognition, knowing and understanding level of the child, right? So pre-verbal sensory motor period, animism, giving life to an inanimate object. A 2-year-old child, less than 2 years of age, they have object permanence, so you can make them explore because they are not aimless play. They like to push, bang, poke. So you can allow children to touch. They want to touch and feel through their senses. Giving life to an inanimate object is something important. So this is kind of something which we have to understand in communication. But what I wanted to do is non-verbal communication, because the child is not going to talk and communicate here. Pick up non-verbal cues. Participate and make your communication through non-verbal cues, right? They are startled by sudden noises, loud noises, right? They have strong taste, smells, right? They have to be on the caregiver's lap. Parental support is important. Modeling won't work. Modeling works only for preschoolers 2 to 7 years of age, which is in the next stage. Tell Shodu can work depending based on their cognition. This is the application. Again, pre-operational period, these 5 things are important. Pretend play, right? What is a pretend play? This is pretend play. So you can act like as if you're a dentist. The child can go home and he will try to act like a dentist to his mother. He can put his toys and dolls sitting like a school and he can behave like a teacher. That's pretend play. Semiotic function includes pretend play, drawing. You allow a child to give a paper and piece of paper and pencil. He will draw and scribble some circles. He might draw a house, a tree, a crow and a sun, a fish in a pond and stuff like that. So they create a mental image and they like drawing. All this is the starting stages. These are hallmarks of the second stage, which is called pre-operational period. Animism is giving life to an inanimate object. The Surf Excel had, right? Giving life. When the younger sister falls into the puddle of water, the elder brother jumps inside, gives life to that and gives it back, hits it back, hitting it back, immediate justice. Wants to make sure eye for an eye, tooth for a tooth, and then he wants to hit it back, right? The last one is egocentrism and centration. Centration is explained by the Beaker experiment. Egocentrism is explained by the 3-mountain experiment. Centration, most characteristic feature is what the child will be looking at. When he walks into a dental office, why do we have a fish tank and a play area? It's a kind of a decentration, a centration which happens. We want to make sure that the child is looking at that. It has to make it feel different, which is very sharp, which is more catchy, which is more attractive is what the child will look at. The child is egocentric at this stage. That means the child cannot understand another person's perspective. The child will not be able to say, don't thumbs up, don't eat chocolates, brush your teeth twice because it will be good for you. The child will not be able to understand what is his perspective is what's the world's perspective. So he will not be able to understand in egocentrism stage, which is still pre-operational period. So visual aspects are important, as I told you, because centration happens, right? Abstract concepts such as health, future benefits are less important. You cannot give them explanation like this. Modeling will work. Rewards will work. As I told you, you can give them gifts. So social reinforcing, right? Material reinforcer, positive reinforcements will work. Concrete operations, the centration concept goes away, concept of reversal, concept of conservation happens, concept of cardinal numbers happen. They go to school, they are in the latency stage of Erikson and Sigmund Freud. Competence, they are going to school 7 to 11 years of age, logical concepts are there. They go by the rule book. I told you, rule book, heteronomous morality. If a child steals 5 chocolates, another one steals 10 chocolates, a child in concrete operation will say a person who stole 10 chocolates has to be given more punishment, right? They go by the rule book, but then they don't understand certain logic. But here you can go with the rule book. You can make them compete. You can communicate like that. You can say who's holding the suction better? Is it the staff nurse or you? Or you can probably establish some communication like that. Formal operation period equates to the adolescent phase. Adolescent phase, I'm telling you, passive resistance. There's also adolescent egocentrism, which is imaginary audience, personal fable, right? The adolescent girls, they think that always on stage, everybody is looking at them. And personal fable, boys think that they are the heroes of their own stories, which is the fables. And they think they're invincible, and it's called invincibility fable. So establishing communication becomes extremely important with this adolescent people, right? But they have hypothetical thinking. They can think logical concepts, abstract thinking. So you might just talk to them and try to understand what their logic would be. And they have autonomous morality. Now they'll say anybody who steals should be punished the same. So that happens in the operation period because their thinking becomes more logical and they have a cognitive development like that. Concrete operations, as I mentioned, it's the rule book, parental presence or absence, modelings and rewards. Rewards and modelings will work. Modeling will work for all preschool children from about 5 years to about 8-9 years. Formal operations, they can reason, they can set their goals. Their views may not be the same as the dentist. As I told you, their peer group influence is different. So child develops an adult understanding of health and being able to take responsibility. So they will be able to take responsibility. So I quickly rushed through the different theories of psychology. But before my time goes away, I only want to tell you that every time look at the age of the child, then look at which category of behavior under Frankel and Wright he falls. In each category, where is this child belonging in Erikson stage? Where is the child belonging in Sigmund Freud stage? Where is the child in cognitive development? How do we apply those characteristic features for this child in practice or in paper? That is how we have to summarize this paper. I'm ready to take up questions if you have any. And these are 2 wonderful articles which you must read before you go for your exam. All the very best for your exams. And thank you once again to ISPPD, Virendra Goyal sir, Baliga sir, and Manoj for giving me an opportunity in this program. Thank you so much.
Thank you, sir, for your insightful presentation. You really set the tone for the day. I would like to take, I've asked for the question, but anybody has a question, they can raise the hand or type in the chat box so that we can ask.
If anybody has a question, probably they can put it on the chat box and we can answer it to them.
Yes.
Is that okay, Manoj?
Sir, please. Yes, sir. Sir, please accept this certificate. Thank you, sir. Thank you for your insightful
Thank you so much.
presentation.
Thank you so much, Manoj, for the opportunity. Yeah. Thank you.
Thank you, sir. Thanks a lot. Now I request Dr. Pavitra to introduce our next speaker.
Very good morning to one and all. Now we are moving on to our next session. So it's my privilege to introduce our esteemed speaker, Dr. Ashwin Rao sir, who will be speaking on the pharmacological behavior management. Sir is the professor and head of the Department of Pediatric and Preventive Dentistry, Manipal College of Dental Sciences, Mangalore. He completed his Masters of Dental Surgery with receiving the prestigious Vidya Tandon Memorial Gold Medal Award. Sir has also been honored with the Best Teacher Award by NIHT 2012 as well as the years 2016 and 17. He has also authored and recognized with the Guidant Dental Academic Excellence Award in 2016-17. He has also published 58 Scopus Index scientific papers and contributed key chapters in renowned pediatric dentistry textbooks. Over to you, sir.
Well, thank you so much, Dr. Pavitra. Yeah, can you please make provision to share my screen here? I think I've sent a request.
Yes, sir. Just a minute, sir.
Sir, now you can share your screen, sir.
Yeah. I hope Dr. Pavitra, please confirm since I'm doing
Sir,
this
we
live.
can see that. We can see your screen.
And plus, you can hear me loud and clear?
Yes, sir.
You're clear and your screen is visible, sir.
All right, so I'll start now. So,
Yes, sir.
yeah, at the outset, let me thank the organizing committee and ISPPD for this wonderful opportunity to share my experiences with the postgraduate students. So the postgraduate student, this is the phase of your postgraduate life, which I would call as the business end of your postgraduate life. Or in cricketing terms, this is what we call as the slog overs of your postgraduate life. So in your slog overs, you have hundreds of things to do. So that is why I'm not going to complicate the subject for you by giving you a lot of resources to read. This is going to be a very, very exam oriented presentation. All right. So in this presentation, I'm going to simplify the topic for you and give you simple, minimal resources to read so that you can go and do well in your exams. That is the only purpose of this presentation here. So the flow of the presentation is going to be like this. I'm going to deal with pharmacologic techniques under these four subheadings: minimal, moderate, deep sedation, and general anesthesia. And the flow of the presentation is going to be like this. First, I'm going to deal with the basics. Then I'm going to pick up questions which have come in the previous exams. And then I'll help you construct answers to these questions. And then I'll give you specific references for you to go and read up so that you can understand the topic. So this is how we are going to go about it. So let's come to minimal sedation. Now, let's come to the basics first. Now, all of you know the definition of minimal sedation. This has been picked up from the quote CJ reference, and this is a reference I'm going to come back to every now and then. So all of you know about this, so I'm not going to elaborate on this. What is more important for the PGs to know is what is clinical minimal sedation. So clinical minimal sedation, according to the American Society of Anesthesiologists, please note all these references as we go along. So clinical minimal sedation is basically less than 50% of nitrous oxide in oxygen with no other sedative or analgesic medications by any rule, or a single oral sedative or analgesic medication administered in doses appropriate for unsupervised treatment of insomnia, anxiety, or pain. So this is clinical minimal sedation. But when it comes to pediatric dentistry, this second indication is not valid. That's because in clinical pediatric dentistry, we also give drugs like, let's say, one single dose of oral midazolam, which makes the child a little drowsy in addition to anxiolysis, which takes it to which makes it a moderate sedation. So it's no longer minimal sedation. So a single oral sedative drug does not apply to pediatric dentistry. So in pediatric dentistry, clinical minimal sedation means less than 50% nitrous oxide in oxygen with no other sedative or analgesic medications by any route. I hope this concept is clear. So when it comes to nitrous oxide oxygen sedation, the thing about MDS exams, it's somehow MDS exams have never warmed up to this particular topic. So there are very few questions if you go through the previous papers where they have asked questions on nitrous oxide oxygen sedation. In fact, I went through the last 10 years of our university papers, and only in 2024 I could see one long essay which was asked on inhalation sedation in pediatric dentistry. But students, rest assured that is going to change now, because inhalation sedation has come of age in India and it's becoming more of a norm. All right, so it's something that it's a topic which is not good to know anymore. It's a topic that you must know. There's no compromise on that. So rest assured, lot of questions on nitrous oxide will be asked in the future exams in pediatric dentistry MDS curriculum. So one of the good resources for you to read is the AAPD use of nitrous oxide for pediatric dental patient resource. This is a very, very good resource for you to go through. This very nicely explains the mechanism of action, the case selection, the technique, the monitoring. So it gives you, it's a very precise resource. Now, one of the most neglected aspects of nitrous oxide oxygen sedation is scavenging. All right, this is one of the most neglected aspects even in the clinics. What is scavenging? All of us know that it is the process of removing the exhaled gases from the operatory. So one good resource, I'm not going to go into the nuts and bolts of scavenging, but a good resource for you to read on scavenging is again this AAPD document on policy of minimizing occupational health hazards associated with nitrous oxide. So it's a good resource. Please do go through this. Let's come to moderate sedation now. Moderate sedation was popularly called as conscious sedation. So earlier, the misconception was that conscious sedation was equated to nitrous oxide oxygen sedation. So what I think is, the MDS exams did not really ignore nitrous oxide oxygen sedation, but what generally the exams did was a lot of questions on conscious sedation was asked, but they equated it to nitrous oxide oxygen sedation, which we now know is not the case. Nitrous oxide oxygen sedation less than 50% is called as minimal sedation or anxiolysis. So the newer terminology, as all of you will be aware, is for conscious sedation is moderate sedation. So when it comes to moderate sedation, this quote reference, this again signifies that moderate sedation has been retermed as conscious sedation has been retermed as moderate sedation. So again, let me not go into the details of this definition. All of you know this and you'll get it in this particular reference. We'll go to the exams. So conscious sedation has been a very common question in the exam. It's been asked as a short answer. It's been asked as a long answer. And I've picked up these questions from various universities, not only Manipal, I've picked it up from various universities. And it's a very commonly asked question. It's also been asked as a 100-mark question, okay, conscious sedation. So now we know that if a question on conscious sedation is asked, we have to look at it as moderate sedation. So how will you deal with an answer for moderate sedation? What you have to do is you have to put these side headings. First, the definition of moderate sedation. The quote reference has already given you that. Then you should talk about routes of administration. Then you should talk about the drugs that are used in moderate sedation. And finally, you should talk about specific guidelines for moderate sedation, right? So the definition we already know. What are the routes of administration? Basically, there are three routes only. Okay, let's not complicate it. The one you have the enteral route, that is the oral or rectal route, which goes through where the drugs go through the first pass metabolism. Then you have the parenteral route, that is intramuscular, subcutaneous, submucosal, intranasal, or intravenous, which bypasses the first pass metabolism. And then you have the inhalational route. I told you again, let me emphasize it once again, nitrous oxide oxygen below 50% is minimal sedation. When you make it above 50%, it becomes moderate sedation. That is because in addition to anxiolysis, the child also becomes a little drowsy when you give it above 50%. So that is why it comes under the category of moderate sedation. So what are the drugs you're going to use? Again, let's simplify it. There are only 4 categories of drugs. First is the sedative hypnotics. These are the drugs which put the child to sleep. Hypnotics, chloral hydrate, triclophos, barbiturates. Then you have the anti-anxiety agents, which basically calm the child down. Anxiolysis they create. These are the benzodiazepines, hydroxyzine, diphenhydramine. And then you have the narcotics like meperidine. And then you have nitrous oxide oxygen above 50%. What are the specific guidelines for moderate sedation? Go through this reference, quote reference. Okay, it gives you specific guidelines for moderate sedation. So this is how you should construct an answer on moderate sedation. Another very good resource, it's one of my favorite resources. This is go through the textbook by Arthur J. Nowak, which is commonly called as PINCAM. Go through chapter number 8, pain reaction control, that is sedation. This is a very good resource, not only for moderate sedation, but it also simplifies nitrous oxide oxygen for you. So minimal and moderate sedation, this is a very simple resource which simplifies all the context. So do go through this reference in addition to the quote reference. Other questions which have been asked. Now, the thing about theory exams is that you may know, the subject of sedation, you may have read about it, but you have 3 hours in the theory exam. So suddenly when a question let's say like this particular question, conscious sedation with benzodiazepine pops up, it is very difficult for you to construct that answer within 3 hours. All right. So one of the things about theory exam is that once you read up the topic, once you are aware of the topic, you have to go back through previous question papers, see what questions have come out from that particular topic, and you have to prepare answers upfront for
We will wait for 5 minutes. I think the unstable net connection has caused this problem. So we will wait for 5 minutes. Then I will call sir.
Yeah, I think I lost the connection. Am I audible now?
Yes, sir, you are audible. You can share the screen, sir.
Yeah, I'll just tell me where you lost me. I'll go back to that slide. I think Zoom was on for a very long time, so that's probably why, yeah, I lost the connection. Okay.
So it was when a question comes of conscious sedation and benzodiazepine. Yeah, exactly. That's right,
Yeah.
sir.
It's here.
Uh, Conscious sedation and benzodiazepine. Yes, this one.
This was the one.
Yes, sir.
All right. So shall I continue?
So
Yes, sir, please.
Yeah. So I was telling you about, I don't know where I lost it. So I'll start with this slide. So the thing about theory papers is that, what happens is, you may know a lot about the subject, you may have read about it, but theory papers, you have only 3 hours. So when the question suddenly pops up on, on conscious sedation or any aspect of sedation, it's very difficult for you to construct the answers to these questions within those 3 hours. So how you should prepare for a theory exam is that once you've read the topic, you have to go back through earlier question papers of various universities, pick up the questions which have been asked from that topic, and prepare your answers up front. For example, now, if a question like conscious sedation with benzodiazepines come, then it's very difficult for you to construct the answer then and there. So, how you have to construct the answer to this question is you have to talk about advantages, you have to talk about mechanism of action of benzodiazepines, and then you can talk about 3 commonly used drugs, that is midazolam, diazepam, and triazolam. So you can go through this particular reference. That is, this is the chapter from Behavior Management in Dentistry for Children by G.Z. Wright. All right, so you can go through this particular reference for benzodiazepines. So midazolam, for example, has been asked as a short answer. Now it's difficult for you to construct this in that 3 hour span. How you should construct it is you should talk about the chemistry of midazolam, the pharmacokinetics, the pharmacodynamics and mechanism of action, routes of administration, advantages, and complications. Where would you get this? A very good reference is the reference by Kupidiskai. It's a very nice reference on midazolam. Midazolam sedation has also been asked as a big 50-mark question. So if you want more elaborate information, you can also go through this reference by yours truly. I have co-authored this book with Dr. Shweta Tiwari. So you can go through this particular book. So which chapters do you have to go through? It's you can go through chapter number 2, Understanding Midazolam, chapter number 5, Routes of Midazolam Administration, and chapter 8, which is called as SAFE, Sedation Attitudes to Forestall Emergencies. Let's take on another question which has appeared: advantages and disadvantages of oral sedative route in pediatric dentistry. See, it's very difficult to register these questions and then construct an answer. So you have to prepare for it upfront. It's been asked as a 10-mark question. So the advantages, all of you know, these advantages are there. I'm not going to go into the details of it. What are the disadvantages? These are the disadvantages. What I will do is I'll give you the reference. Where did I pick this up from? I picked this up from the classic book on sedation. It's too late for you probably at this stage to read the entire book, but once you finish your PG, if you want to practice sedation, this is your Bible. You should go through it. All right. Sedation by Stanley J. Melamed. That is the 6th edition. So go through the chapter 7 on oral sedation. So it gives you the advantages and disadvantages. Now let's come to deep sedation and general anesthesia. Let's go to the basics first. So what are the basics of deep sedation and general anesthesia? Deep sedation and general anesthesia are a continuum. Clinically, the difference is only academic. So basically, all the monitoring, all the infrastructure that you need for deep sedation, you also need it for general anesthesia. In deep sedation, the anesthetist practically works in Goodell stage 1 of anesthesia or the ultralight plane of anesthesia. So that means deep sedation is a stage where the child is floating between consciousness and unconsciousness. All right. Okay, so in deep sedation, the child is practically unconscious unless a deeply painful stimulus occurs, whereas general anesthesia is a state where the child is continually unconscious and unresponsive to any degree of painful stimuli. So you have to understand here that practically in deep sedation, the child is unconscious. Unless you give him a painful stimuli, repeated painful stimuli, he may just open his eyes and give you a delayed response. So what I'm trying to tell you here is that deep sedation and general anesthesia are pretty much the same. All right. Clinically, they are one and the same in terms of infrastructure and personal requirements. There's a misconception wherein, it's thought that IV sedation is equal to deep sedation. Okay, so when someone gives IV sedation, it's considered to be deep sedation. You have to understand that this is not the case. All right. Okay, so you can even give moderate sedation through IV sedation. Like if you titrate midazolam through IV sedation, it leads to moderate sedation when you give it within the prescribed doses. So you have to understand this. In fact, the other end of the spectrum, deep sedation or general anesthesia can also be achieved with any sedative drug or any route. For example, chloral hydrate, if you give it orally in sufficiently high doses, will lead to deep sedation or general anesthesia. So you have to understand this concept very well. Where would you use IV sedation? IV sedation is the preferred route for deep sedation because the anesthetist can use specific IV drugs like propofol or fentanyl, which bring in deep sedation in small doses, ensuring quick and safe recovery. So when would you use IV sedation? If you want specifically deep sedation, then the IV route is the best way to achieve deep sedation because there are specific deep sedation drugs like propofol and fentanyl that the anesthetist will use in small doses to bring in deep sedation, and small dosages lead to quicker recoveries. But if you try to get deep sedation through a conventional moderate sedation drug like midazolam, you have to give it in very high doses. All right. And when you give it in very high doses, it also brings in so many secondary complications because it's not meant to be a deep sedation drug. I hope that concept is clear now. Another common misconception is that general anesthesia involves the uses of gases and intubation, whereas the intravenous administration of drugs without the use of intubation is sedation. So you should be aware of the technique, acronym TIVA, that is total intravenous anesthesia, where general anesthesia is completely induced and maintained intravenously, either with intubation or with an open airway, that means no intubation, depending on the extent of treatment needs. Okay, so basically what this slide says is that, I've seen many videos or posts on social media wherein the doctor claims that, we did treatment under IV sedation. All right. And when you see the video, the child is unconscious. So you have to understand that, he is not doing IV sedation. He is basically treating the child under general anesthesia. General anesthesia doesn't mean that he has to be intubated or gases have to be given. You can get general anesthesia even with only intravenous drugs. All right. And you can even, you don't have to have intubation always. Okay. So even with an open airway, you can do treatment, but there are indications for that. All right. Which we'll come to it later. But I want you to be very clear on this point that it's okay to do do total intravenous anesthesia, but then you should know that you're doing the child is in general anesthesia. You should not assume that the child is in sedation, because when you know that the child is in general anesthesia, you have to have that infrastructure and you should have that monitoring and personnel, all right, to back it up. So this is very important. So now if we are familiar, since you're familiar with the basics of deep sedation and general anesthesia, all right, I'll give you the references which will elaborate on all these concepts. So the first resource I can give you is go through this by Oral Sedation for Dental Procedures in Children by Stephen Wilson. So go through chapter number 10, Deep Sedation and GA. A second reference I'll give you again is the Behavior Management in Dentistry for Children textbook by G.Z. Wright. So you can go through this particular chapter working with the dentist anesthesiologist. All right. So pages number 177 to 184. Go through this reference to understand the concept. A third reference I'll give you is again Melamid sedation textbook by Melamid. That is, but you have to please note here, this is not the 6th edition. This is the 5th edition. All right. The 6th edition doesn't give you this. Go through the 5th edition of Melamid, chapter number 30, Fundamentals of General Anesthesia, and chapter number 31, Armamentarium, Drugs and Techniques. Okay. So go through these resources, which will help you understand the concepts of deep sedation and general anesthesia. So now let's take on a few questions on deep sedation and general anesthesia which have come in the exams. So one question which had come is enumerate and describe drugs used in sedation and GAC. It's very difficult to register this question and then construct an answer. So let's enumerate the drugs. So first we'll enumerate the moderate sedation drugs. I've told you it comes in 4 categories. Okay, we have already discussed this. Nitrous oxide oxygen above 50%. Okay, so what are the deep sedation drugs? They are ketamine, propofol, fentanyl, or analogs like remifentanil. What are the drugs used in general anesthesia? Basically, you split them up into 4 subcategories. Pre-medication can be given with a drug like oral midazolam. Then you induce general anesthesia through propofol, ketamine, fentanyl, or analogs. And then you give succinylcholine to facilitate intubation, and then you give sevoflurane or IV meperidine to maintain the anesthesia. This is one flow of general anesthesia. It depends on the anesthesiologist which flow he prefers. All right, this is one flow of it. So ketamine has also been asked as a short answer. So you can go through again the 5th edition of Melamid. You can go through chapters intramuscular sedation, page number 154. That's a specific page number which talks about ketamine. And then you can go through the chapter called pharmacology. That is chapter number 25, again in the 5th edition of the textbook of sedation by Dr. Melamid. Some more questions. Differentiate conscious sedation, deep sedation, and general anesthesia. Give their indications and contraindications in pediatric patient undergoing dental treatment. This has been asked as a long answer. So why I'm putting up these questions is I want you to understand that, see, I know so much about sedation, but offhand, if you just ask me to, if you give me a piece of paper and tell me answer this question, all right, so I'll also find it difficult to construct an answer offhand. So it's very important for you to, prepare upfront for questions in theory exams. All right, so let's take on this question. So first you're going to talk about definitions. How are you going to differentiate? You're going to talk about definitions. Then you can differentiate moderate sedation and then club deep sedation and general anesthesia. You can go through the quote reference, which gives you that differentiation. All right, so specifically you can go through table 2 in the quote reference, which will give you that differentiation between moderate sedation and deep sedation general anesthesia. Then coming to the indications and contraindications, these are my indications which I practice clinically. Where do I use moderate sedation? On the chair side for children displaying Frankel positive or negative behavior. Where would I use deep sedation with an open airway? I would do it chair side with an anesthesiologist. In children displaying Frankel, definitely negative behavior, where the comprehensive treatment is limited to extremely short dental procedures. Whom would I call as Frankel definitely negative? They are children who actively resist. Whom would I call as children with negative behavior? They are children who allow you to work but keep crying continuously. Who is showing frankel positive behavior? They are anxious children, and you can see it in their eyes. They allow you to work, but one sign of pain, and they'll start actively resisting. So I would use deep sedation with an open airway in the chair side along with an anesthesiologist, where in children displaying frankel definitely negative behavior, where the comprehensive treatment is limited to extremely short dental procedures. For example, let's say extraction of one lower six or upper six, or maybe along with the use of a rubber dam, maybe one pulpotomy with a hall crown. All right. Okay, so I would do that. Where would I use general anesthesia along with intubation? I would do it only in the OT. I would never do GA on the chair side. That's my personal opinion, because even though I've heard people say that we do it chair side in the clinic along with the anesthesiologist, but my argument to that is, even if you're doing it chair side inside your clinic with all the along with an anesthesiologist also, hospital there are hundreds of people, all right, to assist the anesthesiologist. Okay, so in your clinic, you may have one or two trained personnel. So assume something happens to the anesthesiologist. What are you going to do? In a hospital, there'll be backup. All right. So there are places where they do it chairside general anesthesia, but then they have the backup for it. They have the personnel for it. They have, hospital backup immediately. All right, right next door. Otherwise, don't do it chairside. Always do it inside the operation theater. Where would I use general anesthesia? I would use it in children displaying frankel definitely negative behavior, where the child has extensive dental treatment needs, full mouth rehabilitation with extensive use of the aerotor. All right, there I would want intubation to secure the airway. Let me give you also another reference to indications and contraindication. You can go through the behavior. You can go through this particular reference, behavior guidance for the pediatric dental patient. That is the AAPD reference. All right, so you can go through that. There have been upgrades to this. You can go through the upgrades. It gives you the same thing, right? Okay. Let's take on another question. Define sedation. Discuss the goals of sedation as defined by AAPD guidelines. Name the emergency drugs that may be needed to rescue a sedated child patient. This has been asked as a long answer. So goals of sedation, you can go through this behavior guidance reference itself. The emergency drugs, you can again go through the Court Wilson reference. All right. These upgraded references are also there. So please go through that. All right. But it's pretty much the same. There's not been much of a change. You can also go through, for emergency drugs, you can also go through this chapter number 33 in melamine sedation. That is the 5th edition again. I like the 5th edition better than the 6th edition. For some reason, some things have been deleted in the 6th edition. But you can go through emergency drugs and equipment in the 5th edition. This is a very simple, straightforward question. ASA classification system for GA. So this is a very simple, straightforward thing. All right. Again, you'll find this specifically for children in the court reference. All right. Okay. Pre-medication in pediatric dentistry. It's also been asked as role of pre-medication in pediatric patients. Pre-medication is a very big term. It can mean a lot of things. Pre-medication can be anxiolysis before a dental procedure for a good night's sleep, what we do in adults, where you give them, let's say, you give them a diazepam, before, just to ensure a good night's sleep for them. All right. Or it can even mean sedation before GA induction, so that the child is not scared when he's separated from his parents. All right. you can also use it for anterograde amnesia, so that after you give the oral sedative, the child does not remember what is transpiring. So even if he cries during the LA, he may not remember that LA was given later. It can be given to give you, to prevent post-operative vomiting. That is also a form of pre-medication. You can even give it as a preemptive analgesia, which they do it in oral surgery. They give analgesics first before the extraction. So pre-medication can mean a lot of things, or it can also be given to facilitate the exception of the nasal hood in children displaying Frankel's negative behavior. So pre-medication can mean a lot of things. So a good reference for this is the chapter in the textbook by Muthu sir and Shiv Kumar sir, where Dr. Padmanabhan is the first author of this particular chapter. So you can go through this particular reference. Again, there's been a upgrade to this textbook, so you can go through the upgraded version, right? Okay. This question has been asked for 100 marks, pharmacological management of patient behavior. So this is now, with the background of all the information that we have, this is a very easy question to answer. You can talk about minimal sedation, moderate sedation, deep sedation, GA, the drugs. You can answer this question very, very easily. All right. So these are the sample questions that I found. Let's say, yeah, there's another question. Let's take a look at this question now. Conscious sedation versus general sedation in pediatric dentistry. All right, this is what you typically call in cricket as a bouncer, because the terminology is wrong. There's no scientific terminology called as general sedation in pediatric dentistry. So probably what the examiner wanted to ask is conscious sedation versus deep sedation or GA. So probably that was the scientific terminology that was meant to be asked. Okay, so you know how to answer this question when it's conscious sedation versus deep sedation, GA, right? So that's the end of it. So let me conclude the presentation by giving you a few exam tips on the theory paper. So I'll compare the writing the theory paper to a culinary or cooking competition. Okay, so in a cooking competition, you may prepare a delicious dish which tastes excellent, but it looks very ugly. All right, the presentation is very ugly. So what will that lead to? That will lead to a very annoyed chef. He may not even taste your dish. It's very similar in a theory paper. In a theory paper, you may present a very informative answer with a lot of good information there, but you may have written it illegibly or very, very shabbily, and that will lead to an irritated examiner. All right, because you're putting him under a lot of stress to go through all the information that you've written in a very illegible handwriting. So you will end up with less marks. So some of the tips that I can give you is, one is, again, prepare specifically questions from previous exam papers, because that will help you know your construction up front. So then you can write in a relaxed manner. When you're tense, then you end up putting information in a haphazard manner. Structure the answer if possible with side headings. Underline important points for the exam. Tell the examiner, highlight the points. Tell him that you know the subject. Draw margins. This is something we were taught in kindergarten. Draw horizontal and vertical margins. Present your paper well. All right, it improves the appearance of your paper. Optics are very important. Write legibly. All right. Draw schematic diagrams wherever possible. All right, and wherever feasible. For example, do it only where necessary. For example, now if there's a question on let's say the scavenging nasal hood, you can show the flow of gases through the scavenging nasal hood through a schematic diagram, and that will tell the examiner that yes, this candidate knows the subject. But don't put irrelevant diagrams. Let's say the question is the types of cry, then you don't have to put the different types of cry, all right, unless you are you want to make the examiner laugh because you know the poor guy is under a lot of stress correcting hundreds of papers. You want to give him a light moment. Don't put unnecessary schematic diagrams, right? So, dear students, so as you approach your postgraduate exams, you'll have some good days, you'll have some bad days, but here is hoping that you'll have many more good days compared to the bad days. And I hope that all of you go and do very well in your exams. And I hope all of you enter this club called as Pediatric Dentist, the batch of 2026. And I hope that at the end of the tunnel, from students, will all become colleagues now. Wishing you all the best for the exams. And thank you so much. I hope I didn't cross my time limit. I hope it's about 30 minutes. So thank you so much. I hope I made it worthwhile for you. Thank you.
Thank you so much, sir. The lecture was very useful from both theoretical as well as examination point of view. So there was one question in the chat box, which was then eventually answered in your lecture itself. So now we can move on to the presentation of certificate. Sir, on behalf of the organizing committee, so please accept this digital certificate as a token of our appreciation for your valuable contribution. Thank you, sir.
Thank you so much. Thank you. Thank you so much. Thank you. Thank you so much. It's been an honor. Thank you.
Moving on to our next speaker, Dr. Priya Shetty K. She is an associate professor in Department of Pediatric and Preventive Dentistry, AJ Dental Institute of Dental Sciences, Mangalore. She has a teaching experience of more than 20 years, clinical experience of 25 years, certified in inclusive education of ABA therapy for neurodivergent children. Ma'am, it's over to you.
Sure.
Dr. Priya, ma'am. Yeah. Ma'am, you can start your screen for sure.
Yes.
Good morning, everyone. Am I audible?
Yes, ma'am.
Yes. So I will be speaking on the non-pharmacological behavior management in pediatric dentistry. So I would like to introduce this topic to you all by saying a child's behavior doesn't need to be controlled. It needs to be understood. So as pediatric dentists, the success of our treatment, we might be doing a perfect operatory treatment, but if the child leaves in tears, then a treatment is not a success. So on this note, I would like to give the standard definition for behavior management. It says that it's the means by which the dental team effectively and efficiently performs dental treatment, thereby instilling a positive dental attitude on children. This is a standard definition which was given by Wright in 1975. AAPD has now modified it as, the terminology now for behavior management stands at behavior guidance. So what exactly is behavior guidance? So as we are aware, pediatric dentistry involves an interaction between the dentist, the parent, and the child. And behavior guidance is a continuum of interaction which involves the dentist, the dental team, the patient, and the parent directed towards communication and education. So this is a standard definition given by AAPD on behavior guidance. Right. So coming to the most important, what are the 4 goals of behavior guidance? Now, if you're asked a question on what is behavior guidance or what are the goals of behavior guidance? These are the 5 goals which have been given by AAPD in 2015, and I've put the reference down for you to go through. So these are the 5 components or the core goals of behavior guidance. One is to establish communication, alleviate fear and anxiety, deliver quality dental care, build a trusting relationship between the dentist and the child, and you promote a child's positive attitude towards oral health care. So for me, behavior guidance involves you have to have a lifelong nurturing relationship with this child who you want to come back to you in a very positive way, who wouldn't resist treatment, who wouldn't have any kind of fear or anxiety. And this is one specialty where management of the behavior is very crucial to performing treatment. No other specialty in dentistry gives so much of importance to behavior guidance or behavior management or behavior shaping, as we call it, as much as we do in pediatric dentistry. So these are the 5 goals. This comes as a short notes, so you can elaborate this on your own, in your own words, but make sure that you're writing these 5 points when asked for what are the goals of behavior guidance with the reference as given below. Right. This could be another question that is asked. What are the factors that influence a child's behavior? So at every age, the behavior of the child is varied. A child who's below 4 years, what we call them as emotionally immature, the way they behave, and the way a child at 10 years behaves is quite different. So a lot of factors influence the child's behavior, his age, the cognitive development or the understanding capacity of the child, his previous experience. It could be a past bad dental experience, the attitude of the parent, the individual temperament. This was given by Wright and Kupitsky, 2015. So it's a reference from the textbook, the second edition of Behavior Management in Pediatric Dentistry by Wright. So I would like to also highlight here that the behavior of the dentist also plays, there is a component of the dentist also which directly influences the behavior of the child. So how the dental office is appearing or the appearance, how is the setup, your personality. Are you a smiling dentist? Are you short-tempered, or what is your temperament? The time and the length of the appointment. Keep your appointments short. Keep the appointments when the child appears to be fresh and not tired or hungry. Your skill, your speed of work, and your vocabulary. Instead of using any kind of, I don't have to tell you this, but using praise, reward, being attentive, being responsive also plays a major role on how the child is going to behave. Parents, of course, the parent-child relationship, the attitude, the maternal attitude, their anxiety, what is their attitude towards dentistry also influences his behavior. So these are the factors which influences a child's behavior. So this also can be asked as a question. For further reading, please refer to the second edition of Behavior Management by Wright and Kupitsky. Right. Common behavioral responses. Crying, withdrawal, defiance, and non-compliance. I'm sure we've encountered these situations in our everyday practice. So the most common would be crying, non-compliance, withdrawal, and defiance. So how do we manage these, and what forms the framework for behavior guidance in pediatric dentistry? So we have 2 main components in this framework. One is basic behavior guidance, and then other one is advanced. So when we say basic, it's foundational. It's non-pharmacological here again, where in basic behavior guidance, we focus on communication, education, and building trust. So this is the very foundation that we lay down before we start our procedures, before we manage the child in the clinic. Advanced is indicated for patients who cannot cooperate due to their age, due to fear, and in special children with special healthcare needs, or when your alternative communication fails. So this is the 2 main components of behavior guidance. So I'll come to basic because that is what is the topic all about. It's non-pharmacological here again. So in basic, we have the hallmark of basic behavior guidance is communication. Communication and communicative guidance This is associated with tell, show, do, ask, tell, ask, positive reinforcement, distraction, voice control, desensitization. There are others too, but these are the main guidance, the main methods or the techniques that we use, which comes under the broad heading of communication and communicative guidance. Advanced involves sedation, general anesthesia, and protective stabilization. Protective stabilization is a non-pharmacological technique, but in this framework, it is classified under advanced behavior guidance. So what is communication and communicative guidance? In today's era, where we are all virtual communicators with our phones, one-to-one communication, eye contact, and multisensory communication has taken a backseat probably in our day-to-day lives, but thank God to pediatric dentistry, we still rely on communication. It's universally used. It can be used in both cooperative and uncooperative patients. Communication involves the use of certain commands. The main goal here is to establish a rapport and trust with the child. It starts with asking the name of the child, as simple as asking the name of the child, his class, his school, his day-to-day life, or whatever happens in his routine. And once the procedure begins, it's bi-directional. Communication with the child also being an active participant. Do not stop communicating the child once you begin your procedure. Continue communicating to him so that the child is involved and he is considering himself as an active participant in the procedure. So you ask questions, and there has to be an active and reflective listening. So this is the basic foundation that we have to go ahead with our treatment procedures. So here's something that is used, it is known as self-disclosing assertive technique. So as the visuals tell you, making use of simple statements like, I will need you to open your mouth so that I can check your teeth. Be clear, be a little assertive, but at the same time friendly, and your tone should be in a manner which is friendly, and the child will respond to you for you to get the desirable behavior. So it's called self-disclosing assertive technique, which is a kind of communicative guidance again. So this involves communicative guidance entails a positive pre-visit imagery, tell, show, do, ask, tell, ask, voice control, non-verbal communication, positive reinforcement. So when I say positive pre-visit imagery, pre-visit, the child has not yet visited you, but our guidance, behavior guidance starts even before the child enters the operation. The child would have asked for an appointment, you know the child is going to come. So conditioning the child even before the visit or the actual treatment happening also is important, and that is it leads the list of the communicative guidance protocol. So then I go to the slide. Yeah, we also have distraction techniques, desensitization, parental presence or absence, enhancing control, sensory adaptive dental environment, picture exchange communication system, cognitive behavioral therapy, and nitrous oxide oxygen inhalation. So I'll be explaining a few of the techniques in a very concise manner. But if you are asked a question, how would you manage an emotionally immature child? How would you manage an uncooperative child? Or would you, or there could be a question asked on explanation of any of these techniques? So how are you going to write about it, and how are we going to explain about it in a very concise manner? I will be explaining it further. So, right. So what is positive pre-visit imagery? Here the patient previews positive photographs or any images of dentistry related to dentistry and dental treatment before his dental appointment. That is, the patient is shown some stories, social stories, or some visuals, which changes the attitude of the patient and in a positive manner so that he approaches with a positive state of mind. The objective is you provide children and parents with visual information on what they actually should expect during the dental visit. any fear-provoking situations can be managed in a manner by these kind of conditioning. And you provide a child with the context to be able to ask relevant questions before the dental procedure commences. Tell, show, do, again, something that we do this in our regular practice. But if when you're asked a question on tell, show, do, these are the key words that has to come in your answer. So it involves explanation of the procedure in phrases appropriate to the developmental level of the patient. That is, you have to tell it in an age-appropriate manner. What is going to be done in simple words that the child can understand. Demonstrations of the visual, auditory, olfactory, and tactile aspects. You can show the patient, you can make him listen to certain sounds, make him smell, make him taste of the procedure in a very carefully non-defined, non-threatening situation, very slowly showing him, and then without deviating from the explanation and the demonstration, you complete or you perform the procedure. So these are the key points or what has to be coming. Please highlight this when you write your answer so that it explains it in a very appropriate manner as to what exactly you're doing it. So the main objective, so in your question, one would be an introduction of the procedure or the technique, and then will be your objective, indications and contraindications, if any. Also, if a person has introduced this technique, please give credit to the person who has introduced this behavior management technique. The objective is mainly to teach the patient the important aspect of the dental visit, to familiarize the patient with the dental setting, your armamentarium, and behavioral shaping is your main objective. So you're shaping the patient's response to the procedure mainly through desensitization and describing this procedure to the child. Certain modification of tell, show, do. So this is again something which there are a lot of comparative studies which have done. You can get it on the internet with these kind of comparative studies where the traditional tell, show, do has been modified and its comparison has been done with certain modifications such as tell, play, do, tell, show, play, do, ask, tell, ask. You ask the patient something, the patient tells you, and then again you ask. So it's a two-way communication that happens here. Tell, play, do, using your devices or apps. Cognitive behavioral play therapy. Cognitive behavioral play therapy is making use of play in an age-appropriate manner by including the dental procedure or a dental armamentarium as a play thing. Then role play, where the child acts as a dentist with a virtual tool distraction. So here the child will be the dentist in this game or whatever, and he will be telling, showing, and doing the procedure to the virtual patient. Yes, next is direct observation, a very simple procedure which also has a very positive impact on the child. Either you can show a video or a live modeling where the child is allowed to directly observe a young cooperative patient undergoing the dental treatment. Again, here, the objective is you to familiarize the patient with the dental setting and the steps that is involved in a particular procedure. So if you're doing a restoration, show the demonstration of that particular procedure which you're performing on a cooperative patient. This also provides the patient, when you're doing a direct observation, involve the parent also, involve the patient also, so that they're able to ask questions regarding the procedure or the safety of the procedure or any other things which they would like to clear before you start the procedure on the patient. Yes, voice control. Well, voice control is not very practical nowadays because children are pampered. And also some parents might take it in a very offensive manner if you are going to shout at the patient. But it can be used when you know that the child is deliberately trying to avoid treatment, but he has the potential to cooperate with the treatment. So voice control is a deliberate alteration of your volume, your tone, and the pace to influence and direct the patient's behavior. So, however, make sure that you're not shouting your lungs out, but you can probably change your tone and the way you talk so that he listens to you and stops his unacceptable behavior. Here again, the objective would be to gain the patient's attention and his compliance, avoidance, and it's more, this voice control works with a little bigger children, probably beyond 6 or 7 years of age, not in emotionally immature children, because they might end up crying. So age appropriate here again, and it's contraindicated in patients who are hearing. Right. So positive reinforcement and descriptive praise. I'm sure you all have a bag of goodies to give your patients on completion of the procedure and in an award for your desired behavior. So here, positive reinforcement comes under the broad heading of contingency management, but specifically now it comes under even communication guidance, because descriptive praise is what works more effectively than just giving a toy and a verbal praise. So descriptive praise is we tell the patient, thank you for being still, or thank you for enjoying the procedure, or you're doing a great job by keeping the hands in the lap. Whatever it is, describe his behavior and tell him a simple thank you rather than just saying good boy, good girl. All right. Then you have certain social reinforcers where you have a positive voice modulation, a facial expression, a smile, a verbal praise, or any kind of a celebratory gestures like a fist bump. And of course, non-social reinforcers like some toys, tokens, certificates. So this also works to reinforce the child's behavior in future appointments. Yes, distraction technique. This works wonderfully well for children who are below 6 years also, and up to 10 years it works, but you have to be specific on what is the distraction technique that you're going to use. So this is achieved by imagination, storytelling. So we had a postgraduate student who had a bag of stories. So every student, every patient who came to her, she would narrate stories, and wonderful short stories she had, and it worked wonders on the children. Your clinic design is also a distraction for the child. Playing soft music, it's called audio analgesia, or any kind of visual distraction such as television or virtual reality eyeglasses. So distraction techniques, performing magic tricks. We can be the magician also. It works for children who are below 4 years or 5 years. Then you have the traditional distraction techniques where you do not display fear-invoking armamentarium like a syringe, wherein you can camouflage it with some toy or a covering. So that's called a traditional distraction technique. And now, since we're in the futuristic technology-based distraction techniques using virtual reality classes, again, this is a distraction technique. It's coming to the next behavior guidance. It's called memory restructuring. So this works in patients. This is done for patients who have a past negative dental experience, wherein you restructure his memory by utilizing 4 components so that he forgets the past dental or negative experience, and you transforming it into a positive dental experience. So this involves 4 components: visual reminders, positive reinforcement through verbalization, a concrete example, and sense of accomplishment. For example, if a child has this in his first dental visit, the child had to undergo an extraction. So that is going to be in his mind that all my future dental visits are going to be fearful. So you remind him of something which was pleasant to him at that day, on that day, probably an ice cream which was given to him at the end of the treatment. And then you go on through simple language, reinforce this positively by showing him a picture or a video of the same. Then you give a concrete example. You can show another child who was fearful, underwent the treatment, and walking out happy. And then you make him feel that he has achieved a sense of accomplishment. So this involves 4 components. So behavioral science is a very it is based on child psychology. It's a very elaborate science. And how we reconstruct all our behaviors are response to particular situations or a context or a person. So memory restructuring, you forget the bad ones, remember only the good ones, is what we say. So good memories, so we restructure the memories as a part of behavior guidance. Yes, desensitization. Systematic desensitization is a process. So this can be asked as a short notes. It can be asked as for 10 marks, or it could be a part of the behavioral guidance framework itself. So systematic desensitization is a process wherein a child is gradually exposed to his fears or anxiety. Now, the prevalence of dental fear and anxiety is as high as 20 to 27% in almost all children below 6 years. And this technique of desensitization is found to be effective process in exposing the child to a fear. Unless we expose ourselves to fear, we will not be able to overcome our fears. So face it, but how do you face it? So it's in gradual steps where for children, we model actions like simple opening of the mouth, touching his cheeks, using a mirror. The parent can practice it with the child at home to what to expect in the dental office. Successful approximation is done. Ask the child to visit you during the non-clinical hours, not when there is sound or when patients are crying. So in a non-threatening atmosphere, you can ask him to visit your tooth, take him around. So this is also desensitization. Visit the dental operatory, make him familiar with the dentist, the team, your teeth, your instruments. And then a simple appointment where only examination of the oral cavity is done. And after each step is done, you can go into the next step procedure systematically. So here the objective of desensitization is we're gradually exposed to the situations, mainly to diminish his emotional responses to any fear-provoking stimuli. So it's used in patients who have had past fear-invoking stimuli, who are fearful by nature, who are highly anxious, and also it works in patients with neurodevelopment disorders such as children on the spectrum, children with hyperactivity, or speech impaired children. Yes, this is enhancing control or signaling. Here, the child is in control of the situation. Here, the dentist provides the patient a signal. For example, the dentist tells the patient, if you have any pain, please raise your hand. So the child is aware of the situation. He also feels he's under control. And then you can briefly interrupt your treatment if the patient raises himself. Be sure to interrupt or stop your treatment the minute the child raises his hand, because then that gives him the confidence that you are responding to his signal. So the objective is allow the patient to have some measure of control during the treatment, to allow him to control his emotions and also to prevent any disruptive behavior. So it's also called as signaling. All right. So if you're asked a question on how would you manage or how would you design an office setup to manage an emotionally disturbed child or a neurodivergent child or a child with autism spectrum disorder. So this would be something that you would have to highlight. It's called sensory adaptive dental environment. So what is this? So most of the children with sensory disturbance are averse to loud sounds, smells, the clothing or the attire. So you adapt your clinical setting from the conventional setting to adapt to their sensory disturbances, so that there is dim lighting. You have certain calm projections on the ceiling, such as bubbles or the sound of water, the soothing background music, applying a wrap or a blanket around the child to provide a deep pressure input so that you can produce a calming effect for the child whenever he is faced with a situation. So you communicate with the parent, ask them what exactly is the sensory disturbance the child has, and then you adapt the child by modifying your dental environment. So a lot of comparative studies, you will get it on the PubMed also. Sensory adapted dental environments. So comparative studies where they have compared the conventional environment to a sensory adapted dental environment. So please structure your answer, but do not forget to include this when you're asked a question on how would you manage an emotionally immature child or a child with sensory disturbances or autism spectrum. So it's used in patients with autism spectrum, sensory processing disorders, or also in patients with dental anxiety. So making the patient comfy and also making him calm also helps to relieve anxiety and improve his behavior. Right. So we have something known as augmentative communication techniques. Since we also treat children with special healthcare needs, we have children who are hearing impaired, speech impaired, non-verbal autistic children, children with hyperactivity. So in them, where communication is a big barrier, where we're not unable to communicate with these children. So how do we communicate with these students? This is what we use. It's called an picture exchange communication system. So communication should not be limited only to neurotypical, since we also deal with neurodivergence. We have something known as picture exchange communication systems. We have visual reminders. So this is an alternative augmentative communication technique, which is developed for children who have limited or no verbal communication abilities, especially for those with autism and attention deficit hyperactive disorders or children with speech impairment. So you share a picture card with a recognizable symbol to express a request or a thought. So this can be modified. Most of the schools use this, and it's used it in an inclusive setup also, where the child, this is now integrated into computers and apps also, where the child communicates to you using pictures instead of verbal commands. So since we are not trained with this, so a brief overlook on picture exchange communication system before you handle children with speech impairment will help you. Again, you will get a lot of literature on picture exchange communication system, but make sure that you also use the keyword as in dental operators. So this is an alternative augmentative communication technique used for children specifically who have no verbal communication abilities. Right. So something from the conventional, we have what is known as animal assisted therapy. Now, animals such as dogs are used in children who are a trained animal. Of course, the animal is trained, and this provides it's a distraction technique again. So you can see that the child is resting his arm on the dog, who is acting as a distraction to the child and probably would be acting as a fear reducing the stimulus here again to reduce his anxiety, pain, or distress. So it's a trained animal. However, you cannot use it in a child who's already fearful of a dog with the parents' permission. And in children who are allergic to pet hair will not be using this, but it's again used in children. Also, it works well with neurodivergent children also. So animal assisted therapy is a new modification to the conventional behavior management techniques. Right, a small brief talk on mind body therapy. So this involves basically biofeedback, breathing exercises, and hypnosis. However, you need to be trained to do this. So it's basically to relax the mind. Doesn't work with very small children, probably children in the age group of 8 to 9 years and above. So this is used for hypnosis. You have to be trained. Breathing exercises is basically to calm a distressed child. So deep breathing. Biofeedback here again makes use of electrical impulses to know what exactly the impulses are. So how you can reduce it. But all these, so these are all further reading for you all. But you need to be trained in this. However, this can be like a supplemental answer that you can write if we are asked a question. So please read on biofeedback and hypnosis. Right. So though protective stabilization is considered as an advanced behavior guidance, since we have certain legal formalities, we cannot withhold or restrain the child without parental permission. So there are two types of stabilization. It's called active immobilization, where the extremities of the child, his head and the entire body, the movement is restricted by another person. It could be the parent, it could be the dentist, or another dental assistant. That is known as active immobilization. Or passive immobilization is by using certain restraints or physical restraints, such as a pappus board or a mount prop, that is known as passive immobilization. Indication is, now please be sure that when you're thinking of on whom to do it, be clear on the indication. It's only done on a patient who requires immediate diagnosis and or urgent limited treatment. For example, patient who you presents to you with dental trauma, or you need to do an immediate diagnosis where the patient comes to you with cellulitis and is not allowing you to touch. So then immobilization of the patient becomes a necessity. Or there is a developmental delay, a cognitive delay, or an emotional delay, or a mental retardation where he is not having any cooperative ability. You can do it if it is an emergency situation. You can go ahead with immobilization. An uncooperative patient whose treatment needs are limited, that is, it requires only a single quadrant of care, and sedation or general anesthesia is not an option. So with limited treatment needs, but the patient is uncooperative, you can go ahead using protective stabilization. So this kind of sums up the techniques of behavioral guidance. We have certain modern approaches, certain modifications, or certain things that have been done from the deviation from the textbook behavior management techniques. So we have what is known as olfactory stimulation distraction technique, or aromatherapy, wherein certain essential oils like lavender oils or orange oils have been used, and they are found to have brought about a reduction in the salivary cortisol levels. Gustatory stimulation distraction technique, where using a sweet flavor distracts the child prior to starting the dental treatment. Music therapy, soothe music. So distraction therapy can always be augmented with music therapy. So this is basically to make the patient unaware of the distracting sounds, and music now is played when the child is in the operatory. Stress ball distraction technique. We give the child a stress ball which he can pump during the treatment. Then we have another unconventional technique called as writing in the air using the leg. So this was a study done by Kamath et al., where the child had to write his name in the air using his leg during the administration of the LA. So you can read up on it. Then we have another comparative study which was recently published in the Journal of South Asian Pediatric Dentistry, Volume 8. It compared a back flour therapy and thaumaturgy. A back flour was introduced by Dr. Edward Back. It's an organic flour therapy. Again, comes under olfactory stimulation distraction technique. And thaumaturgy is making use of magic tricks and a thumb sleeve. So this was another distraction technique that was used. So you will have a lot of distraction techniques in literature where you can quote for your answers. If you're asked distraction has a specific answer, or conventional versus modern approaches to the non-pharmaceutical behavior techniques. So this is what you can write. All right. So you're going to practice in the future. You're the future pediatric dentist. So please add a note on the future trends. So these are the key points that I would like to highlight here. AI-driven behavioral prediction. So even before the child walks into your clinic, AI is able to predict what kind of behavior the child is probably going to display in the setting. So behavioral prediction. Telehealth consultation. This is also going to be something that is very futuristic, where you're going to consult him online, and then behavioral modification can also be done using this service. Virtual reality, here again, a lot of apps taking over. Games, mobile dental health applications, and of course, interdisciplinary collaboration. So you can collaborate with other disciplines and come to a treatment plan, again, with the help of AI. And this would be what you're going to practice. So please do add a note on future trends or the modern approaches. So I would like to summarize this topic by saying, see, our priority is the emotional well-being of the child. Behavior management is an holistic and an individualized approach Successful behavior guidance goes beyond simply completing a treatment. You are building the foundation of trust, you're eliminating fear, and you want a lifetime of excellent oral health for the child. So this should be your objective, and this is what we should practice at pediatric dentist. So I wish you all the very best for your exams for your future career. So let's take behavioral guidance as your foundation steps to the future practice. So thank you. I'm open to questions.
Thank you, ma'am. Thank you for your informative session. Ma'am, there is one question in the chat box. How you can direct the observation differ from modeling?
No, it's the
How
same.
can
It's a terminal. Yeah, it's the same. It is just a modification of modeling. Modeling is done with live modeling or using any audiovisual aids. Direct observation is a terminology that is given when the child directly observes the patient undergoing treatment.
Okay. Anyone wants to ask any question? Ma'am, there is another question. How to answer a question on how to differentiate between the behavior management of a fearful child and an anxious child?
How to differentiate the management? I didn't
How
get the
to
question.
differentiate between the behavior management of a fearful child and the anxious child, and how to approach this question if this question comes to the exam.
There is no, I don't think there's a differentiation. See, dental fear anxiety is it's a behavioral response, right? So you can use any area of the behavior guidance
Okay.
techniques that are done, I've explained about. So there's nothing that is different. But a highly fearful child who's displaying potentially definitely negative, then we go ahead with sedation. And non-pharmacological techniques will not work. So you will have to elaborate your answer saying that if it's an extremely fearful child, you would go ahead with sedation or your advanced behavior guidance techniques.
Thank you, ma'am. Ma'am,
Yes, thank you.
can we have a certificate? Ma'am, you have to stop sharing the screen.
So what is it? You're not audible, Dr. Manoj?
Ma'am, you have to stop sharing your screen so that we can
Okay,
project
sir.
our certificate.
Okay, okay.
Ma'am, next slide, please. Ma'am, please accept this certificate. On behalf of ISPPD, I am presenting you the certificate regarding.
Should that statement screen?
Hello. Ma'am, are you there? Moving on to our next speaker. Can you change the slide now? Our next speaker is Professor Madhu K. He is a professor and head of the Department of Pediatric Dentistry and Preventive Dentistry at KLE Institute of Dental Sciences, Bangalore, Karnataka. Sir has completed his MDS from the Rajiv Gandhi University of Health Sciences and authored 30+ national and international scientific publication and delivered lectures on minimal invasive dentistry, dental material, and curriculum overview. Sir has served an executive member of ISPPD from 2017 to 2018. 22 to 23, 23, 24, and currently the Vice President of ISPPD in the year of 24 and 25. Sir, over to you, sir.
Thank you, Dr. Manoj.
Can we start the recording?
Yeah. Very good afternoon to all. Next half an hour, we'll just go through a brief overview of Caries Diagnosis Act, very specific. There can be a confusion around the terms diagnosis, detection, and assessment. Diagnosis is the result of a human professional summation of all available information, and current guidance for caries diagnosis is to adopt a multi-step process to help assess the lesion. This involves lesion detection, determining the lesion extent, severity, and assessment of lesion activity, all combined with establishing the. There are various caries diagnostic aids which are available for day-to-day practice. The basic one being the visual-based diagnostic aids, followed by radiation-based, light-based, electric, ultrasound, and various diagnostic aids under development. Visual examination is the most commonly used method for detecting various lesions because it is the easy technique that is routinely performed in clinical practice. The paradigm shift toward the non-surgical management of dental caries relies on early detection of the disease, and detection of caries at an early stage is of unequivocal importance for early preventive intervention. So this visual detection dates back as per the dentistry itself and is still considered to be the most pragmatic method for clinical lesion detection. And for comprehensive caries detection and assessment, the teeth should be examined using the focused illumination, ideally with the magnification with clean tooth surfaces requiring the removal of surface debris such as plaque and calculus. And only half of the technology is recommended. The teeth should be cleaned or dried before the examination process, which, if not included, will increase the risk of missing caries lesions. Various authors like Lucy, Whitehead, Wilson, and Ricketts recommended that visual examination is not an ideal means of diagnosing dental caries as most of the lesions go undetected. Clinical accuracy of visual examination with regards to caries detection is only 25 to 30%. Tactile examination has been criticized because of possibility of transferring cariogenic microorganisms from one side to the other. It is important to note the distribution, quality, the density, thickness, and stickiness, and quality of biofilm deposits as they are removed, as these help inform caries process activity assessment. Loche, Extant, and Stuckey opined that use of Explorer can cause irreversible damage to the tooth structure, which can be utilized. Nigel and Pickett recommended the use of sharp eyes with a blunt probe. A round-ended probe is advocated to check carefully for cavitation by gentle tactile feedback of surface contour and texture, using a gentle lateral sweeping motions over the tooth surfaces. Teeth should be examined both wet and dry, using the 3-in-1 airway syringe. As and when the teeth are dried, earlier detection of initial lesions is possible, whereas moderately deep lesions can be easier to identify when the teeth are wet. Various reviews of caries detection systems included on 29 criteria and revealed that these systems differed considerably in aspects such as definition of dental caries, content, and examining conditions. Various systems like Extant's classification, Mountain View, NIVARDS, Las-Pergus, ICDAS, the ADA caries classification system, PUFA and PRS, CAST instrument, ICCMS, the FTI World Dental Federation caries matrix, caries care 4D, which is the latest. So these classifications try to classify the non-cavitated lesions so that the early preventive treatment can be begun in patients before the cavitation is occurred. The Extant criteria described the non-cavitated lesions from no change or slight change in enamel translucency to a frank cavitation in opaque or discolored enamel exposed in the underlying teeth. So Mountain Hume proposed that if minimal intervention needs to be adopted as a philosophy, there is a need for an entirely new classification that will identify both the position of the lesion on the exposed crown of a tooth and the extent to which it is progressed. It is neither necessary nor desirable to specify any particular design for the cavity, and that may have to be, but it is important to be able to identify a lesion before it becomes cavitated so that it can be subjected to treatment by remineralization and subsequently kept under observation until healed. So Mountain gave the classification in 1998, and it is a site and size classification where they classified the lesions from minimal, moderate, enlarged, and extensive. A new concept, the concept SISTA, define sites of susceptibility and evolutionary stages of the lesion, introduced for each site an initial stage 0 corresponding to a diagnosed lesion requiring strictly non-invasive treatment is added to the classification. This was a modification of mounted view classification. So Nyworth's index described a new set of clinical caries diagnostic criteria which differentiated between active and inactive caries lesions at both the cavitated and non-cavitated levels, and evaluated the reliability of this criteria system in a population with high caries incidence. According to this system, the examination is based only on clinical features of the surface, including color, opacity, and presence of discontinuities of cavitations, classifying the lesions inactive or active. American Dental Association caries classification system was introduced in the year 2015. So this is a proposed caries matrix which provides a springboard for a dynamic and integrated process in which experts can assess consistency and parallels between different caries classification systems. So this ADA caries classification system included the DMF index, DEF index, and ICDS classifications. So this ADA caries classification system is intended to be easy to learn, is designed for using various clinical practice settings, and has commonalities and differences with other caries classification approaches used for clinical caries management and research. For the past 70 years, data on caries have been collected worldwide using DMFT or DMP index. This classical index provides information on caries and restorative and surgical management, but fails to provide information on clinical consequences of the untreated dental caries, such as pulpal involvement and dental abscess. That is when Monse and colleagues developed this PUFA index. This PUFA index records the presence of severely decayed teeth, and classifying them as visible pulpal involvement, ulceration, fistula, and abscess. This PUFA index complements classical caries indices with relevant information for epidemiologists and healthcare. This PRS index is a modification of PUFA index where definitive treatment could not be drawn from PUFA index. So this helped the definitive treatment of untreated caries. Serious difficulties in reporting results were encountered when using ICDAS-2 and PUFA separately in an epidemiological survey in the child population. That necessitated the development of a comprehensive but pragmatic caries assessment index, which is called the caries assessment spectrum and treatment index. Spectrum indicates what is considered the main strength of the index, its usefulness in describing the complete range of stages of caries lesion progression. CAST combines elements of the ICDAS-2 and PUFA indices and M and F components of the DMF index. A DMF score can be easily calculated from the CAST score, thereby enabling retention of the existing DMF scores. The CAST index for use in epidemiological services is found to be very promising in the particular intervention. Now, this is the CAST index, where you can see the classification from a sound pool to the pathological sequelae of the disease. There are a few articles related to CAST index. Now, this FDI World Dental Federation caries matrix, which is proposed by Julian Fisher, Michael Glick, and FDI World Dental Federation Science Committee, consists of a caries matrix, which has 3 tiers, one above the other. The extent of the caries lesion and pathology is depicted in the horizontal axis. The top tier represents the WHO basic methods, it's a DMFT, followed by the bottom tier is full ICDA scores, which provides more detailed level of information and allows for an expanding degree of detail. And the middle tier seeks to describe the DMFT and the ADA caries classifications. The International Caries Detection and Assessment System was developed in the year 2002 by ICDS Foundation. So this ICDAS is an evidence-based, preventively oriented strategy. It classifies the visual appearance of a lesion, characterization, monitoring of the lesion once detected, and culminates in diagnosis. The ICDAS is scored on a clean, dry teeth. The system cautions against using sharp explorers or probes in order to prevent iatrogenic damage to the tooth. The ICDS classification criteria and associated estimates of the caries activity are based upon the histological extension of the lesion spreading into the tooth tissue. The scores are on a 7-point rating scale. This ICD-AS was modified in the year 2005. It is called ICD-2. This ICD-AS-2 has 3 criteria: clinical visual assessment, lesion detection aids, and care planning aids. ICD-AS provides flexible and increasingly internationally adopted methods for classifying stages of the caries process and the activity status of the lesions, which can be incorporated into its international caries classification and management system. These are a comprehensive set of clinical protocols that address all diagnostic, preventive, and restorative decisions necessary to preserve tooth structure and restore only when indicated, which is the mission adopted at Temple University Caries Management Pathways in the year 2012. The International Caries Classification and Management System takes the results of the ICD-AS classification and translates it into a risk-assessed caries management system individualized for each patient. This ICD-AS wardrobe is a wardrobe of validated tools, allows users to select the best criteria and conventions for a specific use. The concept is that the system will be an open one, maintained on the World Wide Web and subject to peer review. Users of the system will have to specifically acknowledge the version of the system they employ and specify the parts of the ICD-AS wardrobe that are being used. This ICD-AS wardrobe includes the DMF component, the PROFA component, the ICD-AS full recording system, and the merged scores. The ICCMS enables dentists to plan, manage, and review caries in clinical practice according to the caries risk and caries risk status. A 4D protocol, which is called as the ICCMS 4D caries management, was proposed according to the plan, including determining the patient's caries risk, detecting and assessing caries lesions, deciding the treatment plan, and do the intervention. So caries risk assessment was involved in the first 2 steps of the 4D protocol. An upgraded system, Caries Care International 4D, was derived from ICCMS in the year 2019. The FDI World Dental Federation publicized and advocated ICCMS in 2019 when the Caries Care International Consensus Guide and 4D Caries Management System was published to aid the delivery of ICCMS into the general practice. The visual tactile examination of caries lesions is not sufficient for assessing interproximal or occlusal surfaces. Therefore, radiography is commonly used to assess and detect caries, as it gives the practitioner additional information about the clinical progression. Over a period of time, distal radiography has gradually replaced conventional radiography due to its ease of image manipulation, enhanced image quality, and improved diagnostic accuracy. The limitations of these radiographs being the routine use of intraoral radiographs, especially for low caries risk patients, has been debated due to concerns about the increased radiation risk. And radiographs cannot distinguish between active and arrested caries lesions, and sometimes between cavitated and non-cavitated surfaces, as the radiographic lesion depth does not always reflect the actual caries lesion. And radiographs only detect lesions with a depth of at least 500 micrometers in the enamel. The inability to detect initial caries lesions limits the clinical use. Digital subtraction radiography is one of the techniques used, wherein 2 radiographs of same object can be compared using the pixel values. The values of pixel from one object is subtracted from the second image. If no change, the pixel is scored as 0. This is used in assessment of progression, arrest, or regression of caries lesions. The main benefit of CBCT is that it can overcome the limitations of 2-dimensional imaging. The accuracy of CBCT in detecting dental caries has shown considerable variability across different studies and literature. In general, CBCT is not advised as a primary diagnostic tool for routine caries detection. The caries detecting stains differentiate mineralized from demineralized dentin in both vital and non-vital teeth. Outer caries dentin is stainable because of its irreversible breakdown of collagen cross-linking, which loosens the collagen fibers. Inner caries dentin and normal dentin are not stained because of their collagen fibers are undisturbed and dense. Many caries detector dyes provide irreversible staining. Their use for diagnostic occlusal caries is not recommended as it would be aesthetically unpleasant. The extent of demineralization can be relatively noticed by intensity of the fluorescent dye, where a higher intensity correlates with more demineralization. Using KRS detector dyes routinely without a proper understanding of the limitations can lead to excessive removal of sound antenna and mechanical bulb exposures. Fiber optic transillumination as a KRS detection technique is based on the fact that KRS enamel has a lower index of light transmission than sound enamel. The light is absorbed more when the demineralization process disrupts the crystalline structure of the enamel and dentin. In essence, this gives that area a more darkened appearance. This method of KRS detection uses a light source, preferably bright light, to illuminate the tooth. KRS or demineralized areas in dentin or enamel show up as darkened areas with distinct. It is only useful for proximal and occlusal lesions. Its sensitivity and specificity are not sufficient for detection of a very early KRS. Besides, it is not quantitative and therefore not useful as a KRS monitor over time. However, there are conflicting results present from the various previous studies. So, FOTI exhibited a better sensitivity than clinical inspection in detecting precavitated lesions that had a shadow or opacity underneath the marginal region. Another study also reviewed the diagnosis of KRS on proximal surfaces and found that FOTI was superior to visual inspection and radiography. A conclusion can be obtained from some previous studies that FOTI is a cost-efficient, non-invasive adjunct to clinical examination in the detection of posterior dental caries. Digital imaging fiber optic transillumination. This is a digitized and computed version of FOTI. While FOTI was designed for detection of proximal and occlusal caries, digital imaging fiber optic transillumination (DFOTI) is used for detection of both incipient and frank caries in all the two surfaces. DFOTI can also be used to detect fractures, cracks, and secondary caries around restorations. This uses a white light to transilluminate each tooth and to instantly create high-resolution digital images of the tooth. It is based on the principle that caries tooth tissue scatters and absorbs more light than surrounding healthy tissue. It is important to note that DFOTI images the light emerging from surface closest to the CCD camera. So it does not image the tooth material between the light source and the CCD camera and therefore cannot indicate the depth of the penetration. The dark areas in DFOTI images may sometimes be due to the stains or calculi on the tooth surface. Therefore, it is suggested that prophylaxis should be carried out prior to the use of the device in order to increase the specificity. So QLF technology was introduced in the year 1995. The recent development of QLF incorporates the red fluorescence detector, excitation of red extensing fluorophores from bacterial metabolites by blue light causes plaque, calculus, or bacterially infected caries lesions to appear red on a bright green background, enabling the use of QLF to quantify and monitor plaque. Diagnodent is a laser fluorescence system that detects changes in tooth structure due to demineralization. One weakness of this technology is that all bacteria, not only caries-related bacteria, produce fluorescence. A lot of organic and non-organic materials such as stains, plaque, and calculus, and trophy-based food, and even tooth itself can cause fluorescence. In any case, one of the advantages of the system is that it quantifies the nature of its readings and gives a basic guideline as when to intervene. So other fluorescence-based equipment such as fluorescence camera, proof, the Sopralight. Caries scan is based on the proven technology of alternative current impedance spectroscopy that involves the passing of an insensitive level of electrical current through the tooth to identify the presence and location of the decay. It is the first dental diagnostic tool to use AC impedance spectroscopy to quantify dental caries early enough to enhance preventative treatment. It is indicated for detection, diagnosis, and monitoring of primary coronal dental caries, which are not clearly visible to the human eye. A systematic review comparing caries scan with the clinical visual examination by Diagnodent reported that caries scan has a superior sensitivity and specificity over other methods. The Midwest Caries ID detects differences of optical behavior inside the tooth related to change in tooth structure, and it is therefore not sensitive to bacterial content. One of the few studies evaluating this device reported that sensitivity and specificity higher than that of diagnosis. Interproximal detection using Midwest caries area and X-rays are the gold standard, showed a sensitivity of 80% and specificity of 98%. Opaque artifacts like plaque, calculus, and organic plaque can cause false positives. Other techniques based on electrical conducting measurements like Vanguard, electronic caries detector, and caries meter. In the ultrasound techniques, live TT concept basically is a light-induced fluorescence evaluator for diagnosis and treatment. So this is a new intraoral LED camera that emits visible blue light and was used in the in vivo study to illuminate and photograph teeth at high magnification. The images created with the intraoral LED camera revealed significant variations in fluorescence between sound deadened and active and arrested caries processes, which helped in treatment process. The Canary system, developed in the year 2009 by Quantum Dental Technologies, uses the photothermal radiometric modulated sense. This combination of PTR and LUM has been developed into analytical caries diagnostic tool of combined specificity and selectivity, substantially better than that of diagnostic, radiographic, and visual methodologies. Just another device using light transformation is DEXIS Review. This the DEXIS Carie View is essential companion tool for 2D and 3D digital X-rays. While biotech radiographs are highly effective at evaluating dentin and bone health, NIRTI is used as a second opinion to confirm or rule out suspicious areas of decay, checking for airline enamel cracks and monitor early demineralization. These are the two articles comparing the visual inspection of the various fluorescence sets. And this is an article where visual inspection is compared with radiographed fluorescence-based diagnostic methods. In this paper, demonstrate the same pattern of accuracy in almost all the subgroups. However, the visual inspection demonstrated superiority in the type of lesions most encountered. All lesions in occlusal surfaces of primary and prominent teeth, and even more importantly, it was the same as other methods for other types of caries. This is a recently published article on artificial intelligence platforms for dental caries detection, systematic review and analysis. Here, this meta-analysis found 21 different AA platforms. They came to the conclusion that significant variability exists in AA performance for detecting dental caries across the AA platforms. This demonstrated that AA has superior sensitivity and equal specificity of detecting dental caries from clinical images as compared to biodynamically. Although AA is promising for dental caries detection, further refinement is necessary to achieve consistent and reliable performance across varying variable countries. Now coming to caries risk assessment. Caries risk is the probability that a specific number of new lesions will develop and a specific number of existing lesions to progress over a specific period of time. Now, why caries risk assessment should be done? Because it is a basic component of decision making. One, at first visit and every 2 years it should be repeated. And how? First thing is business as usual. This is a routine clinical examination, what we do in the dental practice. And past clinical experience is one of the single risk assessment factor, which is predictive of future caries, followed by structured models of protocols and computer-based programs. There are various single factors here: tools, salivary bacterial level, salivary property, salivary immunoglobulin level test, and plaque pH. These single factors here tools measures only one parameter to determine the caries risk distribution. It is simple to conduct. However, when compared to multiple factors here tools, it is less comprehensive and no management recommendation along with these tools. These are the various form-based caries risk assessment tools and algorithm-based caries risk assessment tools. The CRA form of American Dental Association, APD, Canberra, OHR, Index caries risk, which is recently developed. Algorithm-based tools of the Karyogram, Divisor, Trap, NUSCRA, and mice model. The ADA provides separate form-based CRE tools for children and adolescents. One is for those aged 0 to 6 years old, and another is for the patient aged over 6 years. The forms are available on the website of ADA. The latest update was in 2011. The conditions like fluoride exposure and sugary food intake, general health conditions like special needs, and clinical conditions like visible plaque are taken into consideration for this form. The AAPD provides separate form-based CRE tools for children and adolescents. One is for the children aged 0 to 5 years old, and another is for patients who are 6 years. The forms are available on the website of AAPD with latest updated social, behavioral, and medical risk factors, clinical factors, protective factors, and research indicators are taken into account for CRE tools. And the risk categories are low, moderate, and high. The American Academy of Pediatric Dentistry recognizes that caries risk assessment and management protocols, also called care pathways, can assist clinicians with decisions regarding treatment based upon a child's age and patient compliance, and are essential elements of contemporary clinical care for infants, children, and adolescents. Care pathways are the documents designed to assist in clinical decision making. They provide criteria regarding diagnosis and treatment and lead to recommended course of action. The pathways are based on evidence from current peer-reviewed literature and the considered judgment of expert panels as well as clinical experience of practitioners. Care pathways for caries risk management in children aged 0 to 2 and 3 to 5 years old were first introduced in 2011. And the care pathways are updated frequently as new technologies and the procedures and philosophy known as caries management and risk assessment, as we know it as CAMRA, published in the Journal of Californian Dental Association in 2007 and updated in 2019 for patients aged 6 years to adult, as well as for young children aged 5 years. The CAMRA questionnaire developed by Californian Dental Association in 2002 is a tool that assesses the risk in caries based on patients' needs. The original model establishes 4 risk categories: low, high, and extreme. This approach includes a clinical evaluation of caries patients and proposes specific interventions for each risk level. In 1996, Rattal and Peterson introduced the careogram model, a caries risk assessment tool designed to predict an individual's risk and guide personalized preventive strategies. Unlike traditional approaches that rely on isolated risk factors such as bacterial counts and fluoride exposure, careogram integrates multiple determinants of caries development, including dietary habits, oral hygiene practices, bacterial levels, salivary properties, and systemic health conditions into single output, a pie chart representing the probability of avoiding caries. The careogram model is a well-established risk assessment that can be effectively utilized in low resource settings to evaluate the burden of dental caries in the population. Its integration into clinical practice and dental education system is essential for providing valuable insights into caries prevention and having more targeted and effective preventive methods. And the American Academy of Pediatrics has developed this tool to aid in the implementation of oral health risk assessment during health supervision. This tool has been subsequently reviewed and endorsed by the National Interprofessional Initiative on Oral Health. Instruction for use, this tool is intended to documenting caries risk of the child. However, 2 risk factors are based on the mother and primary caregivers oral health. Previsor is a risk assessment tool that was designed with the clinicians and the patient in mind. Key characteristics include scientific validity, simplicity, ease of use, immediate results, and applicability for a wide range of patient ages. An easily understandable digitized report is provided that facilitates patient acceptance and compliance with preventive treatment. The promising result obtained from existing caries risk assessment tools combined with the need for a more practical application in everyday dental practice led to the development of a novel, modern design to maintain efficacy while simplifying the evaluation process. It's called the Index of Caries Risk. The Index of Caries Risk for the ICR is a newly designed pediatric caries risk assessment tool that was never used in the studies. This tool examines the classical risk factors and indicators, but also considers the unique characteristics and limitations of the population under examination. This approach ensures a quicker collection of patient information and includes an assessment of parental and rural status. Additionally, the ICR eliminates the tests that require significant time and strict patient collaboration, which can be particularly challenging in the pediatric patients. My Smile Buddy was developed to be an interactive caries risk assessment tool for children and their parents' educational purposes. This caries risk assessment tool can be performed by patients themselves by inserting data without clinical evidence. Diet course and comprehensive risk score can be calculated concerning the level of caries risk. My Smile Buddy provides suggestions for intervention to reduce the caries. NUSCRA, or the National Ministry of Singapore Caries Risk Assessment Tool, is an algorithm-based framework used by dental professionals to quantitatively predict a patient's risk of developing new cavities. It is highly regarded for its excellent balance of sensitivity and specificity, particularly in the pediatric population. The NUSCRA model assigns numerical scores to various clinical, biological, and lifestyle variables to calculate a personalized caries risk probability. It assesses the interplay of pathologic factors and protective factors. It typically utilizes two formats: screening model and comprehensive model. So this is a study which evaluated the validity of four caries risk assessment programs. That is the CAD, CAMRA, KU, and CRA, in predicting early childhood caries among preschool children. Results indicated that algorithm-based programs like NUSCR will outperform reasoning-based programs in sensitivity and specificity. With NUSCRA comprehensive model meeting the criteria for a useful CRA. The findings support the use of NUSCRA for identifying children with caries risk, aiding in tailored prevention and treatment plan. This systematic review, conducted in the year 2019, assessed 8 different caries risk assessment tools. We identified caries risk assessment tools CAMRA, NUSCRA, My Smile Buddy, Dundee Caries Risk Assessment Model, University of North Carolina Risk Assessment Model, University of Michigan Caries Risk Assessment Model, and ADA Caries Risk Assessment. Overall, the NUSCRA studies reported the most information, and this tool attained the higher quality weighting than other caries risk studies with increased highest sensitivity and specificity. This caries risk assessment for treatment of the CRAFT tool was developed by Dr. Ashwin Javadekar. This is a chairside, non-invasive, and simple method for assessing caries risk in children. It uses a 4-point scale, very low, low, moderate, and high, based on 4 key parameters: diet, decay, fluoride exposure, and other factors. CRAFT aims to provide a framework for dentists to customize risk-based caries management plans and encourage patient participation, particularly for Indian children. A recent review in the year 2024 concluded that caries risk assessment is beneficial for developing patients' dental care plans. However, the evidence is limited for supporting its use as evidence-based practice for management. More well-designed studies are needed to assess the sensitivity and specificity across the. This article from Tvetman, Fontana, and Pedestal concluded that past caries experience is far from ideal, but the most important single risk component for more caries at all ages. Any clinical sign of likely active demineralization, smooth occlusion, and proximal to surfaces should be taken as a signal for the implementation of individually designed preventive and disease management budgets. And to conclude the recommendations from an article from Tvetman, caries risk assessment should be carried out in the child's first intro visit, and reassessment should be done during childhood. Multivariate models display a better accuracy than the use of single predictors, but this is especially true for preschool children. There is no clearly superior method to predict future caries and no evidence to support the use of one model, program, or technology before the other, and the risk category should be linked to appropriate preventive caries recall intervals based on the individual need. And finally, I would like to thank the office bearers of Indian Society of Periodontics and Preventive Dentistry for giving this opportunity to present the lecture, and Dr. Manoj Jaiswal and team at Oral Health Sciences Center, PGMR, Chandigarh, and thank the moderators for their time and best wishes for the postgraduate students for their future exams and their future. Thank you.
Thank you, sir, for your informative session. So we would like to present a certificate of appreciation. Can we have a certificate right now? So please accept this. I think sir is not there. Sir has an appointment in passport office. So
just reached
sorry.
Manoj.
Sorry, sir.
Just back.
Okay, sir. Sir, please accept this certificate.
Thank you, Manoj.
Thank you, sir. Thank you, sir. Moving on to our next speaker, Dr. Kalpana Bansal, ma'am. She is currently serving as a professor of pediatric and preventive dentistry at the Center of Dental Education and Research, AIMS, New Delhi. She completed her post-graduation from PGMR, Chandigarh, and has 27 years of teaching experience, including 19 years of postgraduate training experience. An accomplished academician researcher with 100+ international publication and nearly 1,600 research citation. She has successfully led several research-funded projects by the extramural agencies as a principal investigator in the field of pediatric dentistry. Recipients of the prestigious recognition including Fellow of ISDR Award, Fellow of ISPPD Award, AIMS Research Excellence Award, Fellowship of the Faculty of Dental Research and Surgery, Royal College of Surgeons and Physicians, Glasgow. Her major area of interest include caryology, remediation, caries prevention agent, early childhood caries, and silver diamond fluoride. Over to you, ma'am. Ma'am.
Thank you so much, Dr. Manoj.
Thank you, ma'am.
I'm honored to be here to present my lecture on minimally invasive dentistry. And I hope postgraduates find it beneficial, and all the very best wishes to the postgraduates who are going to appear for their final examinations. And certain topics I have covered in brief to cover this vast topic of minimally invasive dentistry. It's a recorded lecture. Now I can present my lecture. Thank you. And my dear colleagues, before I start with the topic of minimally invasive dentistry, I would like to express my heartfelt gratitude to the organizers of this rapid revision and to the ISPPD Executive Board for giving me this opportunity to speak on this platform. These are the contents of the lecture. And in this, first of all, I would explain the concept and the philosophy of minimally invasive dentistry. How did it evolve? Goals and principle. Importance of MID in pediatric dentistry. Advantages and various kinds of interventions which we can perform at various levels of the disease. Historically, dental caries was thought to be a progressive disease resulting in destruction of the tooth structure, and the carious lesion was completely surgically removed and a restoration was placed. However, with the decades of the research in the field of caryology, we now know that dental caries is recognized as a controllable chronic disease that can be identified, diagnosed, and managed using the biological approaches. So understanding of the caries process has changed, and it is now recognized that surgical intervention and restoration of the tooth will not stop the disease. We know that dental caries occurs as a result of interaction of the biofilm with the frequent refined carbohydrates intake, which in turn lead to acid production and demineralize the tooth, leading to the carious lesion. So in order to halt the progress of the carious lesion, it is very important that we remove the biofilm effectively. So how did this concept evolve? This concept of minimally invasive dentistry evolved as a consequence of our increased understanding of the caries process and the development of the adhesive restorative materials. such as GIC and composite materials. It's now recognized that demineralized but non-cavitated enamel and dentine can be healed, and that the surgical approach to the treatment of a carious lesion along with extension for prevention as proposed by G.V. Black is no longer tenable. It's now acknowledged that in the presence of fluoride iron, it is possible to remineralize or heal the earliest carious lesion, and thus in many cases a surgical approach may be unnecessary and can be replaced by a biological or therapeutic approach. So presently, the complete removal of all carious dentin was recommended in the past, but no longer for managing deep carious lesion in vital teeth. Why so? Because the goal of the incomplete carious removal is to maintain the tooth vitality by avoiding the pulp exposure during carious excavation. While we excavate or remove the caries, it is very important to maintain the residual dentin thickness over the pulp. So basically the purpose of incomplete caries removal is to avoid the pulp exposure, because avoiding pulp exposure will improve the lifetime prognosis for the tooth. So coming to the concepts of MID, MID is a philosophy of dental care concerned with early identification of disease, identification of the factors contributing to the disease, and interventions to arrest the disease, and if needed, restorative treatment by minimally intervention techniques. So why is it important for a pediatric dentist? Because in our field, children have increased anxiety and fear. So in order to get better patient cooperation for preservation of primary teeth in a painless state till the exfoliation stage, because MID will involve less need for the local anesthesia use and rotary instruments. So it is very helpful for use in pre-cooperative, anxious, special healthcare needs and with limited access to care children. So coming to the goals of MID, as I've said earlier, to maintain, to preserve the healthy tooth structure as much as possible, focusing on prevention, remineralization of early carious lesions, and in case restoration is required, then the minimal restorative interventions. The principles of MID were coined by Mount and Hume in 1997 and then further in 2005, that first and the foremost principle is the accurate and the early diagnosis of caries. It's very important when the patient comes to us, not only to just render the treatment to the most painful tooth, but also to diagnose the oral cavity as a whole, so as to detect the lesions at their earliest stages, and so that we can implement the preventive agents. The second principle of MID is the risk assessment. I will cover this in the subsequent slides. Prevention of disease progression, remineralization of early lesions, minimal removal of tooth structure using minimal cavity designs, and the last principle of MID is repair rather than replace the restorations. So in case restorations are faulty, it is better to repair them rather than completely replace the restorations, as the replacement of restorations will further weaken the tooth structure and it might break in subsequent time. So coming to the caries risk assessment, this is a very important principle of minimally invasive dentistry in pediatric dentistry. Whenever there are several tools available for risk assessment, out of which the most common used are Canberra, AAPD caries risk assessment tool, and Cadiogram, so as to categorize the patients into low, moderate, and high risk. The clinical importance of this step is to determine the preventive and the operative treatment strategies based upon the risk of the child to the caries. So MID interventions can also be classified on the basis of at various levels. It can be at the patient level or it can be at the tooth or the lesion level. So at the patient level, how do we practice MID? It is by aiming to re-establish the mineralization balance. Basically, dental caries is a disturbance in the mineralization of the hard tissues, and so at the patient level, our aim should be to re-establish this balance by actively involving the patient and the family to facilitate sustainable behavior changes at home, by diet counseling, which is aimed at reducing the frequency of the carbohydrate consumption, oral hygiene instructions, including the use of fluoridated dentifrice, and by professional application of fluoride. At tooth lesion level, the interventions can be in the form of the remineralization of non-cavitated lesions, caries arrest of active carious lesions, sealing caries, removing caries, and the restorative treatments by the minimal invasive techniques. Now coming to the advantages, it preserves healthy tooth structure, it's associated with reduced pain and anxiety, and most MID interventions do not generate aerosol and can be used in situations where aerosols need to be minimized. So that is the reason that MID became more and more popular during the COVID-19 pandemic. Moreover, MID techniques are cost effective. So coming to what MID approach should we take up will depend upon the presence or the extent of the caries. If there is no caries, in that case preventive agents will be applied, and in case of the enamel caries, indenting lesions which can be moderately deep or deep lesions, or when the caries is nearing pulp, or when caries is entering into the pulp. So the strategies of the minimally invasive technique will differ. So coming to how do we take up or handle the carious lesions when they are at the enamel level. So enamel carious lesions can be smooth surface or they can be involving the Pitt and Fisher surfaces. So for the smooth surface early enamel lesions, 5% sodium fluoride varnish or APF gel fluoride foam can be applied professionally, topically, and we can also recommend home use of the topical fluorides like dentifrices and mouth rinses. So recently CPP, ACP has also been added as an adjunctive in the preventive therapy, like they are available as GC, MI paste plus, recaldent chewing gums. MI varnish is also becoming commercially available nowadays, which is a combination of CPP, ACP and fluoride. So in order to take care of Pitt and Fisher caries in the earliest stages, sealant applications is the choice or preventive resin restorations. So in order to take care of white spot lesions, white opacities of MIH, proximal non-cavitated lesions, a technique has come which is minimally invasive by the name of resin infiltration. And what is this technique? This is a micro-invasive drill-free technique which involves infiltrating low viscosity resins into porous enamel structures to seal and strengthen lesions, halting their progression. So its aesthetic benefits make it particularly suitable for treating post-orthodontic white spot lesions and non-cavitated caries in pediatric patients. The ability to preserve natural tooth structures while minimizing discomfort aligns perfectly well with the principles of MID. So coming to the carious lesions into dentin. When the dentin has been affected by caries, in that case, we can arrest the caries by the use of the topical application of 38% STF. Then there can be second strategy, non-restorative cavity control. These strategies I will explain in detail in the next slides. Thirdly, it can be the sealing the carious lesion with Fisher sealants and resin infiltration in non-cavitated dentin occlusion level lesions. And fourth technique which we can use is the halt technique. So for lesions in dentin, STF is gaining the maximum popularity nowadays worldwide. It was first introduced by Yamaga in Japan at Osaka University in late 60s. It is antibacterial and remineralizing in nature. It has been used for managing dental caries for decades worldwide. It was introduced to arrest dental caries in children, and during the era of high caries prevalence in children and shortage of dentists in Japan in 1970s, STF was widely adopted in community dental clinics to manage dental caries in young children. So chemically, what is the structure of silver diamine fluoride is, it's an alkaline solution consisting of fluoride, silver and ammonia, available as clear odorless liquid in concentrations of 10, 12, 30 and 38% under the brand names of Fetchman, ESTF, Cariostatic, Caristop, Bioride, Cephoride, Advantage Arrest. 38% STF consists of 24.4 to 28.8% weight by volume silver and 5 to 5.9% fluoride at pH 10. fluoride concentration is 44,800 ppm, which is twice that of the fluoride wattage. So idea of making this agent was to combine the powerful antimicrobial properties of silver with the benefits of high doses of fluoride. This formulation also results in a precipitate that occludes dentinal tubules and reduces the hypersensitivity. So SDF has a wide range of therapeutic effects. It is bactericidal in action, reduces the collagen matrix breakdown, it helps tooth remineralization, prevents demineralization, it inhibits the keriogenic biofilms. SDF functions by forming a protective layer of silver protein complexes that inhibit bacterial activity, while fluoride ions promote enamel remineralization. So coming to the clinical efficacy of caries arrest by using SDF, a systematic review has shown the caries arrest up to 81% in active lesions over a follow-up of 30 months. Multiple SDF applications are necessary for reliable caries arrest. Two studies in children have demonstrated 91 to 93% caries arrest rate after 2 to 3 years of biannual application, while with annual application, this has been shown to be in the range of 65 to 79% after 2.5 years. So a dose response relationship has been seen using 38% SDF with better outcomes associated with more frequent application. So coming to advantages of SDF in various clinical situations, it's very, very helpful in young children, special needs and phobic patients who have a fear of getting the dental treatment done using dental purr. It can also transform child's first experience as pleasant one, instilling trust and making subsequent appointments with dental professionals more successful. It's minimally invasive in nature, preserves the tooth structure because we have simply we need to apply the SDF solution onto the carious dentine, and therefore the chances of further tooth loss pulp getting exposed are subsequently reduced. When we use SDF, we don't need to excavate caries, so we are preserving the tooth structure. Arrested caries lesion may not require a restoration until and unless the patient or the parent wants to improve the aesthetics, form or the function, and it is inexpensive and also it needs relatively short shear time. So coming to main disadvantage of SDF is that it causes dark brown discoloration of the caries dentines. This is because of the formation of the silver phosphate precipitation. However, it may not be much of a concern if we are using this in posterior teeth. And also whenever we have to use this, we must always inform the caregivers, the parents, and the child that how the lesion will look like after the SDF application. And it is always important to have a informed consent from the parents and the children in case they can consent, they can assent. Now coming to the next minimally invasive technique, non-restorative cavity control. So the principle of this NRCC is that caries can be halted by restricting the sugar intake and its frequency in the diet, and secondly by improving oral hygiene practices using fluoride toothpaste. So aim of this technique is to reduce the keriogenic potential of the lesion by altering the environment of the plaque biofilm overlying the carious lesion through brushing and dietary advice. For the lesions that are not readily cleansable, where dentin is not exposed or there are enamel overhangs, the lesion shape should be altered, making the lesion more cleansable, which will help in plaque control. The basic purpose of this technique is to reduce the etiological factors of the dental caries so that the biofilm does not get accumulated into the lesion, and also by various home care measures. So NRCC is suitable for which teeth? It is suitable for a primary tooth with arrested caries or when the tooth is unrestorable or close to exfoliation with no signs and symptoms of infection. A primary tooth with an advanced lesion with no signs or symptoms of infection where alternate methods are not feasible. So the decision to take up this technique for managing a tooth will depend upon the individual patient basis. So if the patient is able to maintain oral hygiene and comply with your instructions of restricting the sugar intake, this technique can be successful. Now coming to the next MI technique, halt technique. The concept of halt technique was given by Ains et al. In 2006. It involves using preformed metal crown. It was introduced first of all by a general dentist from Scotland by the name of Dr. Norna Hall. Hence the name. The procedure involved is the crown is placed without LA, caries removal or tooth preparation. Appropriate size of the preformed metal crown is chosen and filled with glass ionomer cement. Then the crown is fitted over the carious primary molar by either the dentist fingers pressure or the child's biting force, thus sealing caries under the preformed metal crown without caries removal. The advantages of this technique is that it has been shown to have high success rate. There is no need for drilling or anesthesia, and it increases the child's compliance. However, this technique will be beneficial only in the cases of the lesions which are involved in the dentine, which are far away from the pulp, and there is no risk of the pulp involvement. In those cases only this technique would be successful. So we have to carefully select the case for the Hall technique and not the case of the teeth with the deep lesions. Now coming to the minimally invasive approach for shallow to moderately deep lesion. So first we need to know what is a shallow to moderately deep lesion. The lesions not reaching the inner third or 1/4 of the dentine are considered to be shallow to moderately deep lesion, where there is no risk of pulp exposure. This we can make out on the radiograph. So such teeth should be taken up for the selective removal to firm dentine using ART, non-restorative caries control, or by Hall technique. Now coming to the minimally invasive approaches for deep caries lesions. So deep lesions are those one where the caries is extending till the inner 1/3 or 1/4 of the dentine, where there is a risk of pulp exposure if we completely excavate the caries. So there are certain interventions that avoid pulp exposure in vital teeth, such as shown in these figures with deep caries lesions, and those interventions are like indirect pulp capping, atraumatic restorative technique, SDF modified ART, selective caries removal to soft dentine, stepwise caries removal, and Hall technique. So indirect pulp treatment is a conservative procedure for deep caries. It aims at avoiding pulp exposure and preserving the tooth vitality, has got high success rate. It involves removing most infected dentine while leaving a thin caries affected layer over the pulp, sealing it with the biocompatible material. Indication is deep caries without any sign of irreversible pulpitis. There should not be any spontaneous pain or abscess history. Procedure is a single session technique. It is common can be applied in primary teeth where the tooth is cleaned and permanently restored without reopening, allowing for remineralization of the remaining affected dentine. Material which can be used for pulp, indirect pulp treatment are like calcium hydroxide, zinc oxide, or MTA. Benefit is that it prevents premature loss of primary teeth, avoiding space loss, malocclusion, and impaction of the successor tooth. Now coming to another most common technique which uses the principles of minimally invasive procedures is ART, atraumatic restorative technique. This technique involves the removal of soft caries, decay affected dentine using hand instruments, followed by restoration with glass ionomer cement. So only hand instruments are used, so there are advantages. It causes minimal pain, it is highly acceptable to anxious patients, and there is no need of any electricity. It's child friendly and also cost effective. So its indications are the community settings for young and anxious children, for special needs children who are extremely scared of the dental noises and the drill, and it is best for small single surface cavities in primary or permanent teeth, though it can be used for multi-surface cavities in primary teeth. There are evidences that have shown that multi-surface cavities in primary teeth can also be successfully restored with ART. While highly effective, ART is generally reserved for small to medium-sized cavities. It is not recommended for deep cavities that show signs of pulp exposure or spontaneous pain. So cumulative 1 year success rate of 75 to 90% and 2 year survival rate of 65 to 80% have been shown by a systematic review by Jiang et al. 2020. And now coming to another minimally invasive technique which is gaining popularity nowadays, which is known by the name of silver modified atraumatic restorative technique. This technique has been used has a combination of STF with ART, and the technique has been labeled as SMART, in which carious lesion is first excavated with hand instruments, same as in ART, and then STF is applied. The cavity is then replaced with GIC restoration. STF is applied and immediately restored with the GIC restoration at the same appointment. We have also seen that it can be single visit, it can be multiple visit, and both have shown almost the similar success rates. SMART is special in a way since it addresses many issues encountered in the pediatric clinic. It's very useful for the uncooperative, anxious or fearful patients. It's a simple technique, does not involve the use of dental drill. It's low cost. Comparable success rates have been shown with the traditional restorative techniques, and the success rates vary between 54 to 85% at 6 to 12 months depending upon the location of the caries. So SMART is generally recommended for the control of dental caries, primarily in individuals who are at high risk of caries, who have rampant caries or severe ECC, who have active cavitated carious lesions in the anterior or the posterior teeth, when there is a behavioral issues, and moreover SMART technique may be employed to address several carious lesions in a single session, thereby optimizing time and the resource utilization. However, there are certain contraindications of SMART. It cannot be used for extensive cavitations that have reached the pulp or the patients who have allergies to silver. It may not be optimal for the restoration of anterior teeth or the teeth located in prominently exposed regions, mostly due to associated discoloration. So to identify the suitability of the SMART or other restorative methods, one must evaluate the individual patient as well as the specific attributes of the carious lesions. So it is very important that one must assess each patient whether this patient can be taken up for the SMART, because it is mostly successful for the children who have behavioral issues, who have high risk of caries. So then SMART will be a very good technique to be taken up for the caries management. Now coming to the next part, the chemomechanical caries removal agents. These are minimally invasive agents that uses chemical agents to soften the infected dentin, allowing it to be gently scraped away using hand instruments. So it eliminates the need for the traditional drilling, significantly reducing pain, vibration, and the need for LA. So examples are CariSolve, Pepper Cari. And the advantages of using this in the MI dentistry is that it will cause less discomfort, reduced anxiety, preserves the tooth structure, selectively removes only the decayed tissue, leaving healthy dentin intact. However, there are certain limitations that it is time consuming and it will be costly because of the agents involved. So now coming to the deep lesions where there is irreversible pulpitis. So in such cases, how do we proceed? For managing the irreversible pulpitis in primary teeth, which do not show any clinical sign of swelling or the radiographic evidence of periapical infection. So in such cases, pulpotomy is increasingly explored as a minimally invasive alternative to pulpectomy. Because pulpotomy leaves the healthy root pulp completely intact. So pulpotomy is increasingly being used nowadays as a minimally invasive alternative to pulpectomy, and it promotes healing. A medicament is placed to the remaining vital pulp tissue which stimulates healing. It involves less operation time and it is single sitting. And a recent systematic review and meta-analysis published in 2026 in Journal of Dentistry has shown that no statistically significant difference could be found between pulpotomy and pulpectomy for managing irreversible pulpitis in primary teeth without clinical signs of swelling or radiographic evidence of periapical infection up to 12 months of follow-up. However, the certainty of evidence is very low. Only 2 studies were included in the systematic review and meta-analysis. Careful case selection is required, and the preoperative and intraoperative signs and symptoms shown by the pulp can also serve as a guideline in choosing pulpotomy over pulpectomy or extraction for the irreversible pulpitis affecting the primary molars. And a recent paper has also been published where there is, which has a title of Pulpotomy for Treating Primary Teeth with Irreversible Pulpitis, a call for action. And therefore, pulpotomy is also increasingly becoming popular for certain teeth with deep lesions which show irreversible pulpitis, but without the clinical signs of swelling. So coming to the next strategy in MID is the lasers. So lasers have been in use since decades, and it has been applied in caries detection. Diagnodent has been very commonly used. It's a commercial product using laser fluorescence technology. Then for caries prevention, for soft tissue procedures like gingivectomy, frenectomy, soft tissue dyed lasers are used. For cavity preparation and for pulpotomy, Nd:YAG laser can be used. So different types of laser are available for different applications. Advantages of using laser is that there will be reduced pain and vibration associated with their use and well tolerated by children. So better healing is there, and it also lowers the risk of infection, inflammation, bleeding, and swelling. So a laser is one of the very important technique in the minimal invasive dentistry. Now, coming to the limitations of MID. So wherever we have to use the minimally invasive techniques, it is very important that the patient should be regularly followed up. And also various MID techniques they are all technique sensitive, means a lot of precautions and thoroughly proper steps should be followed up and proper diagnosis should be made before following any kind of MI technique. There are sometimes aesthetic concern with the use of STF in metal crowns, as in the Hall technique, and MID may not be suitable for all lesions. So coming to the future directions, so in MID now the bioactive materials are becoming available which may help in remineralizing the adjacent tooth structure, which is actually retained for the longevity of the tooth. Then is AI based caries detection is another field which is coming up nowadays. 3D printing in pediatric dentistry can also ease the patient's discomfort and the child's cooperation can be improved. So conclusion of my lecture is that minimally invasive dentistry represents a modern evidence-based approach in pediatric dentistry that prioritizes prevention, preservation, patient health, and long-term oral health. Thank you very much.
Thank you so much, ma'am, for such a detailed lecture. Ma'am, as I can see, you have addressed almost all the questions in the chat box. So would you like to elaborate on any of the questions, ma'am?
So one question was there, how to differentiate between selective caries removal and stepwise. So selective caries removal means we don't have to remove the caries completely. We have to look at the texture of the dentine, and in case we are doing caries excavation in a deep lesion, we have to do it very conservatively and not reach into the land up in the pulp. So we need to excavate till the soft dentine. Whereas in case of moderately deep or shallow lesions, we may do it till the firm dentine. Initially, the concept was that it was the caries removal till the hard dentine. Now that concept is gone and we have to remove the caries selectively, looking at the texture of the dentine and the depth of the lesion. And stepwise caries removal, where the caries is removed in 2 steps, which are at a gap of 2 visits. Basically, steps means visits, which may be at a gap of a few of months, years, maybe 10 months or a year, but it's not that common or practiced in primary dentition. It is more applicable for the permanent dentition, because permanent teeth, because the tooth is there, the thickness of the tissues is more. So stepwise caries removal, as the name is indicating, the caries is removed in the steps, in 2 steps, where we allow the time and the tertiary dentin is laid down and the affected dentin gets remineralized. So you need to read that reference which I have given here, and plus there several other papers are also there about this. Selective caries removal is now the in thing for the excavating the caries. We just do it with the hand instruments. Thank you.
Okay, ma'am. Thank you so much. Ma'am, there is one more question. Does direct pulp capping come under MIT?
Direct pulp capping is an accidental exposure of the pulp. It's an iatrogenic exposure where the exposure is not surrounded by the carious dentin. So first of all, we have to see whether it is the carious exposure of the pulp because of the whether pulpitis is there. But in the case of direct pulp capping, where do we do direct pulp capping? We do direct pulp capping where there is an accidental exposure and actually the tooth and the pulp is sound. It is healthy. It is not. So we just cap it with the pulp capping agent. So it is not considered as a. It is not in the field of the MIT. It is rather managing a tooth where there is an accidental pulp exposure during the cavity preparation. So we must try to refrain from using the over enthusiastic cavity preparation with the burrs, with the rotary, with the handpiece. Reason being that the primary teeth are very, very small in size and chances of pulp exposure are very, they can be there if it is not judicious cutting of the tooth at the floor, because pulp horns are also high. So direct pulp capping will not be coming into the technique of the MIT. But yes, we must be careful that yes, we must not start doing the pulpotomy, because if we compare the direct pulp capping with pulp, in that case, we must take care that we have to be minimally invasive, and DPC is kind of a minimal procedure.
Thank you so much, ma'am, for patiently
I hope
answering the
I
questions.
answered this question.
Yes, ma'am. So can we have the certificate? Ma'am, on behalf of the organizing committee, this is a token of appreciation for your valuable contribution. Thank you, ma'am.
Thank you so much. Thank you. Thank you.
Yes. So with this, we have now come to the conclusion of forenoon sessions. So let's now take a short break for lunch. So I kindly request all the participants to come back sharply at 2 o'clock to start with our post-lunch sessions. Thank you.